You should start at 6 o'clock.
Okay. So good evening, everybody. On behalf of ISA Borivali, I invite you all for this second continuation of our bulletin cases. The first CME, which was offline, it was very well appreciated, and the case presentations were really very interesting, and everybody felt that we should have. So here we are with the second part of bulletin cases. This will motivate many of you to send your cases to bulletin issue and be a part of such CMEs in future. I will not take more time. Let us start with our first. I'll just hand over to Dr. Rajesh Rao, and we will start with the case presentations as soon as possible. Thank you.
Thank you very much. As you said, rightly said, cases are being discussed and people are liking it. So more and more people should come and start presenting cases. That is our endeavor. We are going to have very interesting cases today, and good cases. Before I hand over to the multiple COS programs, I want more and more people to help all those who are volunteered. Secondly is the picnic, which the young details of which will be put shortly. A lot of things will be happening for the first time. So we go to all these next events before.
Dr. Rao, your voice is not clear. Your voice is not clear. Yeah, go ahead.
Hello, the signal was lost. I think Tejveer, you can continue now.
Yes, sir. Yes, thank you, sir. We begin with our first presentation today. It's a case about cardiac arrest during LSCS. It is being presented by Dr. Prajakta Kulkarni. Dr. Megha Sutaria is also involved in the case. She will be there, but presentation will be by Dr. Prajakta Kulkarni. Dr. Prajakta is an MBBS DNB. She is a consultant anesthetist in private practice for last more than 20 years. Prajakta, please share your screen.
Good evening, everyone. Actually, I'm unable to share my PPT. So, shall I send it to someone? Can somebody do it?
You can send it to me. I'll send you my email ID.
Yeah.
Till then, you can start. Yeah.
Yeah. One second.
Send ID on WhatsApp.
Yeah. Hello. I will start. I've
Yes.
sent it to Dr. Rao actually. So if you can share the screen.
Yeah, right.
Good evening, everyone, respected teachers and friends. I'm Dr. Prajakta Kulkarni presenting this case on behalf of Dr. Megha, who was primary anesthesiologist during the case. We work together as team in Cloud9 Hospital, Malad. This case was posted there, 37-year-old female, gravida 2, Para 1, leaving 1. She gives a history of previous cesarean section 8 years back. Presently, with 37.3 weeks of pregnancy associated with pregnancy-induced hypertension and gestational diabetes. For blood pressure, she was on labetalol 100 milligram twice a day. And for diabetes, she was on glycomate 1 gram twice a day and injection Tresiba 15 units in the night. She was well controlled on that and she was posted for elective cesarean section on that day. All the investigations were normal. Hemoglobin was 10.3. Two PCV units were reserved. USG Doppler was also normal. On the day of surgery, morning HGT was 123 milligram per cent. She was taken in the pre-operative room. All monitor was attached like pulse oximeter, NIBP and ECG. IV line was secured with 18 gauge pen flow on the left hand. Police catheterization was done. Injection pantoprazole 40 milligram and injection ondansetron 8 milligram was given intravenous. Injection Supasafe 1.5 gram in 100 ml NS was prepared. Apparently, the test dose was given in the ward. So, sister started the IV infusion and she was taken in the OT. In the OT, the monitor was attached and like sister noticed that patient was complaining of difficulty in breathing. She had that choking kind of sensation. She immediately called Dr. Megha, who was in another OT. On examination, there was a wheeze and patient was unable to speak. Dr. Megha advised to give injection derifylline intravenous and injection hydrocortisone 100 milligram IV. 100% oxygen mask was put, oxygen mask with 100% oxygen was put. Patient still continued to have the difficulty in breathing. She asked to prepare the nebulization, but patient started desaturating fast up to 86%, and she advised injection aminophylline. 2 cc was given, but the patient desaturated fast and through convulsion and became unresponsive, and there was asystole on the monitor. The code blue was activated and the help was called. Chest compression started immediately by surgeon. LMA number 4 was put and ventilation with 100% oxygen was started. Is it anaphylaxis? The thought came into the mind because it was immediately after Supasafe injection was started. So injection, the defibrillator was there in the OT. Injection adrenaline 1 milligram IV given start and shock with the 200 joules DC was given. Immediately the cardiac compression were resumed. Ventilation with 100% oxygen was anyway continuous. There was no response. Again, after 3 minutes, the injection adrenaline 1 milligram repeated and shock with the 200 joule EC was given. The cardiac activity was resumed and there was a sinus rhythm also. Pulse, the monitor was like pulse was showing 163 beats per minute, blood pressure 160/100 and saturation of 86 to 88%. 6.5 number endotracheal tube was put, removing LMA on the tube exchanger. Saturation picked up to 93 to 96%. Pulse was maintained with the sinus rhythm. Blood pressure was 126/74 mm of Hg. Second IV line was secured. 100 milligram hydrocortisone was repeated. Injection Lasix was given. Patient was kept under monitor continuously. She was maintaining her vitals. Blood was sent for investigations like ABG, CBC, cardiac markers, DIC profile, electrolytes, LFT and RFT. On ABG, there was metabolic acidosis with pH of 6.9. Sodium bicarbonate 100 cc was given. Ventilation with tidal volume of 600 ml and respirated 16 minutes was continuous. Patient was maintaining the vitals. So USG was performed. The fetal heart was good. Patient's relatives were explained about the mother's condition and the decision of cesarean section was taken with the high risk consent. Patient by that time was showing some signs of breathing, spontaneous breathing. So she took under with the propofol 100 milligram and vecuronium 4 milligram was given. LSCS was performed. Female child of 3.7 kg was delivered. After delivery, carbetocin 100 microgram was given and midazolam 1.5 milligram. Patient was maintaining her vital parameters. Second ABG was sent, which was normal. Baby was also fine. Patient was shifted to critical care hospital for intensive care management in the cardiac ambulance by anesthetist and surgeon. He was kept on ventilator for 24 hours. All the investigations were repeated. Next day morning, patient was extubated, awake and oriented. So probably this was the arrest following the anaphylactic reaction to antibiotic, which was picked up immediately, managed efficiently, and the patient was revived successfully. Both the mother and baby are fine. Thank you very much.
Because that was a very concise and fast
Yeah.
presentation. And we grasped a
The
few things.
arrest in the arrest
Yeah.
we have to take the fast steps. That's why.
Yes.
Maybe.
Yeah. But discussion will require some time.
Yeah.
See, you thought it is anaphylaxis. Was there any ECG attached during the procedure?
Yes. Yes.
So
ECG
what
was
rhythm did
attached.
we see?
No, when she became through the convulsion and unresponsive, there was asystole.
In this reviving, you mentioned about DC shock very early.
Yeah, because the thought of anaphylaxis came, that's why adrenaline was given, and then it
Okay.
was showing the signs of that's why she was defibrillated then.
Okay. And okay. Sorry, I have to read your case from the bulletin to to ask things because
Yeah,
the
I'm sorry,
presentation.
but there was some.
It's okay. It's okay.
I had taken it on camera.
Yeah. It's okay. Was the test dose given like whenever we say
Yes,
antibiotics? So do we give test dose regularly? And
yes. The
if we have
protocol
given,
in
does it
the
reduce your liability?
actually the test dose is given because that's a protocol in the hospital, but that doesn't mean that the patient will not get reaction. I feel.
And Dr. Parnatakar has asked whether you had given a lateral tilt during CPR because it's a pregnant patient. Uterus
Yes,
compressing on the.
left lateral tilt was given. She was on OT table. She was
Yeah.
taken in the OT table, and that's why the monitor was attached. And then she started complaining. So the thing is, the management becomes little easy actually.
People are very much
Uh,
interested. There's a
Can I just
another.
in the chat box.
Yeah, yes, please.
Sorry to
I have
interrupt. There are
Dr.
two questions.
Yeah, one second. Dr. Ashwin Joglekar is now taking the questions from the chat box. I needed some
Yeah.
help, so Ashwini,
And
please go ahead.
Dr. Megha, if she can join me, that will be better.
Yeah, Megha is there as participant.
Yeah,
I
I'm
would
there.
request her to, yeah, if possible, answer questions, whatever.
Okay.
Ashwini, please go ahead.
Okay, hello. The
Yeah.
project,
Hello.
there are two questions. Yeah. Regarding the antibiotic, there are two queries as to what was the volume of the antibiotic given, and in the sequence of events, after how long of administration of the antibiotic did you notice these changes? These are two questions regarding the antibiotic.
Immediately after 10 minutes, we saw the symptoms.
10 minutes
Yeah.
time after giving
Means
the
the patient
antibiotic.
was given
After
test dose in the recovery room, and then she was shifted in the OT. So it took almost 10 minutes, and immediately in the OT, sister came to me saying that she's having some breathlessness, and I was in the neighbor OT doing LSCS only.
So the test dose was given and the antibiotic was not yet given, you mean to say?
Test dose was given in the ward. And then the antibiotic preparation was done in 100 ml NS. That infusion sister started.
Okay. There's another query that was asking about the cardiac markers. I mean, I think this debate will be a little later on whether could it be CCF? Because they have a question as to if the cardiac markers are elevated. Would you label it as anaphylaxis or depending on the markers? They did suggest anything
So-
like a CCF is what.
Later on, all the investigation was done. They were normal. That's why we are thinking that it could be the
Anaphylactic.
arrest following anaphylactic reaction.
Okay, okay.
There's a question.
Can I ask one question, Tej?
Please,
Yeah.
madam.
Uh,
Yes.
So the one thing, Prajakta, you mentioned was that you gave CPR in left lateral. Ideally, in a
Tilt.
pregnant woman, yeah, with a tilt. Ideally, it has to be little tilt, but you have to push the uterus, gravid uterus
Yeah.
to the left, so that
Yeah.
the IVC compression is prevented, and the chest has to be straight, because otherwise your compressions are not effective. That's what
Yeah.
I attended one webinar for pregnant patient CPR, and that is where it was mentioned that little tilt you give, but it is more you should keep one nurse or somebody to
Yeah. To
to
push the tummy
grab it.
on the left side.
Yeah, so that because if you tilt the patient on the left, then your patient doesn't remain straight and your compression
Compressions
is.
may not be.
Yeah, and second point I wanted to make was, once I had this the patient had a reaction to antibiotic. Patients FHS had means that was before in the ward. They realized patients FHS were decelerating and all. They immediately wanted to take up for Caesar, and that time only test dose had been given. But only after test dose also this happened. The FHS became very erratic. So they wanted to take up for Caesar. And by the time patient was brought to the OT, FHS settled down. So they said, okay, maybe we can wait. But then we left it to the husband. Husband said, no, I would prefer that if whatever you decide. So the gynecologist said, no, we go for section. And you won't believe it, the newborn fetus had rash on the body.
Oh.
Yes, Dr. Mascarenhas was there. He was the pediatrician, and the newborn had rash. So it was such a severe reaction, which had even the child had demonstrated some sort of, or maybe the child was the one who was allergic,
Affected.
and that's why that FHS became irregular. And then immediately after the child was born, I mean, everything was fine. Mother was fine, Bachu was fine. We took the patient up for Caesar immediately. But this is what, did you notice any rash on the baby, the newborn baby?
No, no, no.
No, 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 no.
No. Okay. Because this one I remember very well. Okay, the newborn child had rash on the body, and that's how we realized that it was a allergic reaction to antibiotic.
Yeah.
Can I ask one question?
Yes, sir.
Yes, sir. Please.
Once you say it is anaphylactic shock, there has to be presence of bronchospasm on auscultation. Was that done?
Yes.
Yes, it was
That,
there.
that only
yes.
confirms, because otherwise the reaction without a bronchospasm is not termed as anaphylactic shock.
In fact, sir, there was no rash. There was no skin rash. In fact, there was the first symptom was difficulty in breathing and bronchi present.
Bronchi, that is most
I
important.
mean, wheeze present.
So that
Yeah.
time it should have been given adrenaline, should have been given. Why
Yes, but
deriphyllin? Why aminophylline? Why steroid? Only drug which acts on anaphylactic is
yes.
adrenaline. That should have been given first.
Yes, sir. That
Correct?
should have been given first. But the thing is, that time the thing is
No, you put your stethoscope.
Symptoms were mild.
Any reaction patient, stethoscope, bronchospasm, you have to give adrenaline. Aminophylline doesn't work that much. Deriphyllin doesn't work. They are all analeptic drugs. They have bronchodilator effect. But the treatment for anaphylactic shock is adrenaline. Yeah. That should have been
Yes,
given
sir.
first.
Yes, sir.
Yeah,
But
before patient develops arrest, before patient develops arrest.
before patient
Yeah.
arrest, it should have been given. But the thing is, the sequence was so fast that the
I
PIH
understand.
patient desaturated and convulsed,
But
and then there was
the
a systole.
sequence of medicine should have been this. sequence of
Yes.
medicine should have been adrenaline first and other drugs.
Yes, sir.
No
Yes, sir.
AVL,
Sir,
no
but with the
steroids.
case of PIH, would you still give adrenaline first? Would
You are
go for
treating anaphylatic. You are not treating PIH here. You are
But
No,
treating
you're not
anaphylatic.
PIH. The first symptom was difficulty in breathing. That's why I'm saying.
There was a spasm. They said there has to be associated this fall of blood pressure and other things also. Patient
Yes.
becoming and then arrested. It
Yes.
gives you time to give before the arrest occurs. That's
Madam,
what
can
you
I
get.
ask one question?
Okay, carry on. Sorry.
Yes,
Can
Sandeep.
I ask one question? Madam, immediately after intubation, what was the status of ETCO2? Was it used? What did you see on the ETCO2 graph?
Megha.
Exactly, I don't remember about that.
I think in the notes it
But
is
the patient was, the vital parameters. I mean, the ETCO2 was also used, and the patient was apparently maintaining all the parameters. Means pulse, BP, saturation, ETCO2, everything.
Prajakta, there was a question whether you should have gone for baby delivery during arrest itself, immediately after the arrest, instead of trying to revive and then thinking whether we can save the baby. Just a question,
That's
but
that's a
question from Paliwal sir, yeah.
like cesarean section during arrest. That's a very debatable question, and whether. But the thing is, I mean, the thing patient once arrest, I think I don't know, that decision has to be taken by with the gynec and relatives depending on discussion. But I don't know, means that question is always debatable. Ki when to perform the cesarean section. Even that answer we have actually not got yet. No one has
In
got.
how much
Ki
time
when
did you get the patient out of the situation? Like at least to the stable BP level.
it,
It
10
took
minutes.
44.
No,
Total.
the 10 minutes we could revive the patient, but the thing is
Within
we
10 minutes,
observe the patient in the OT for 30 minutes
yes.
before we take the decision of cesarean section.
That was the point. If 10 minutes have gone, whether that will compromise the fetus, and
Yeah, that can compromise the fetus.
whether you
That
were
can
sure that
compromise.
you'll be able to revive. Because even after you have revived,
No, we were not sure. We were not sure about whether we will be able to revive the full-term patient. So that's why even the surgeon, I mean the gynecologist was not also ready to take the decision of cesarean section that time.
Dr. Tej, can I ask?
Even actually we want answer for this question to when to perform the cesarean section in full-term arrest.
No, that is correct.
See,
I just want to ask one thing. Whether
I
this
would like to
testosterone,
ask.
Shilpa, can I ask 1 minute?
Yeah, pucho.
Whether this this antibiotic testosterone was given subcutaneously or intravenously? Because after giving subcutaneously, you wait for at least half an hour to see whether
the antibiotic dose was given subcutaneously in the ward, and then the patient was shifted. Patient was taken in the preoperative room, and then IV catheter. IV
because it was said
then,
that it was given and started, and you brought it now. That's why I'm just asking you. Second thing is, now the child needs all parameters of the child development. That is to be seen now with the pediatrician. Then it will become more interesting. That how much time
we followed up. For the patient had come for the follow up also. This case happened when around 3 months back. When
3 months
so
back.
the thing is, the patient was in April it happened. In fact, in April, in March it happened, and in April bulletin we had presented it. Yeah. So the thing is, so baby and mother had come for follow up. All the testing of mother was done later on also, and everything was normal, and the baby and mother are fine.
Okay. So all milestones are okay.
Yeah.
Okay.
Shilpa, your last question.
No, I just want to add early perimortem cesarean section, not for the baby, to help better resuscitation in mother.
Yes, for the mother. So in any array, the mother is important. So that's why we first try to stabilize the mother. And when there was like assurance, Samki, that we have revived and patient is stable, the cesarean and the fetal heart was good, the cesarean section was done.
Okay. No, what I mean to say is the obstetricians say that
Yeah.
if the obstetric anesthesiologists say that if you remove the baby, then resuscitation in mother is easy.
Mother is easy. Mother is helpful, more helpful.
And we give test dose intravenously, you give subcutaneously for antibiotic. We give subcut for local anesthetic, and for antibiotic, we give intravenous test dose.
In
More
many places they
reliable
give
is subcute.
There are many places they give subcut.
And in
They
our
put
place
a
also they give subcut.
they put a circle around it and see for the player or anything around that. So that is how it is done. So timing is written on that.
I think we'll move on to the next case because there are quite a few, comments coming up. We can read it in the chat box. We'll just move to the next this thing presentation. It is about anesthesia for acute GI bleeding. By the way, Prajakta and Megha, well done. Your patients are fine. So whatever you did was right in retrospect. Although AHA would have said that after 5 minutes of CPR, you should have thought of peri-bottom section first. Thank you.
Thank you.
So we move to anesthesia for acute GI bleeding. This will be presented by Dr. Shagufta Chaudhary, and she had Dr. Yogendra Singh to help, but presenting is Dr. Shagufta. Dr. Shagufta is, one sec. I'll have to read.
Okay.
You can, if you have a CV slide, you can please show it.
Yes, I will show. No problem. Hello, good evening, everyone. Am I audible?
Yes.
Yes. Good evening, everyone, respected seniors and my dear colleagues. Today, I would like to present a case of acute GI bleeding, anesthesia management.
Shagufta, please identify yourself also. Please introduce yourself.
Yes, sir. Okay, is my screen visible now?
Yes.
Yes. Okay. I'm Dr. Shagufta Chaudhary, done MD Anesthesia from Bombay Hospital in 2008. I've also done MBA Hospital Management. Published a few articles in Bombay Hospital Journal. Special interest is daycare anesthesia. I also attended the 12th Congress of International Ambulatory Surgery Society in Beijing, in China, where my book was launched, Handbook of Anesthesia and Daycare Surgery, and also presented a few talks, some of which at Bhaktivedanta in daycare surgery. Currently, I'm practicing as a freelance anesthetist in Meera Bhayandar. So let us go ahead with the case. A 23-year-old, otherwise healthy male was admitted in the ICU in view of severe hematemesis for further evaluation and management. Since he was vomiting blood copiously, he was posted for urgent OGD-scopy. Even without waiting for the CBC report, blood was cross-matched urgently and 2 units of Paxils were ordered. He was A positive blood group. At the time of OGD-scopy, about 1.5 hours after admission, the CBC report had also come, which showed hemoglobin of 8, WBC 14,000 and platelets 70,000. He was conscious, oriented with slight tachycardia, BP 90/50, saturation 100%, with some sinus tachycardia, and the respiratory system was clear. The OGD-scopy was done under TIVA with ondansetron 4 mg, 1 mg midaz, and 50 mics of fentanyl, and 50 mg of ketamine was given slowly. By this time, second Paxil was on flow. The endoscopy revealed an arterial spurt arising from the duodenum. The gastroenterologist was somehow able to clip the bleeding vessel. Looking at the endoscopic picture, one more Paxil was ordered and the patient was shifted back to ICU for monitoring. This is the endoscopic picture. I have just taken the clip of the duodenum where you can see the spurt coming with each pulse. In the ICU, the patient continued to have hematemesis and started having melena also. The right IJV line was taken and fresh CBC was sent, which revealed a hemoglobin of 5.8. 2 units of Paxils were ordered and 2 units of FFP were ordered, and blood bank was notified of the emergency situation. They were requested to stock more blood products. Now, in spite of ongoing volume resuscitation, the BP was dropping. So noradrenaline support had to be started to maintain the mean arterial pressure above 70. Urgent DSA was done under LA to find and embolize the bleeding vessel. By this time, the pulse was about 140 to 150. BP was about 85/50 on NORAD at 8 ml per hour. Mostly the vessels were in spasm and DSA did not reveal any culprit vessel. The femoral line that was taken was now used as arterial line for BP monitoring, and repeat endoscopy was called again. The Riles tube was showing some brownish aspirate, but now there was frank blood in stools. Volume resuscitation was going on with blood products pushed fast. 6 Paxils and 3 FFPs were given already, and 1 single donor platelet was also ordered. At the time of repeat OGD scopy, he was on NORAD support 80/50, pulse 150, saturation 100%, oxygen given through nasal prongs. The patient was looking pale, exhausted, slightly drowsy. It was done under monitored anesthesia care. It revealed some oozing from the clipping site. Adrenaline was injected at the base and temporary hemostasis was achieved. However, the patient's condition worsened within the next hour. The whole exercise was done in order to control the bleeding endoscopically. However, as soon as the little bit pressure used to increase, there used to be fresh bleeding in the stools, and the patient's condition was deteriorating. Now, urgent blood reports then showed a hemoglobin of 3.3 grams per cent and platelets of 39,000. Creatinine was still normal, INR 1.3. Electrolytes were normal. Ionized calcium was 0.9. And ABG was slightly acidotic, near normal. Then vasopressin had to be started to maintain the mean arterial pressure of 70. Urgent call was given to the surgeon in view of ongoing internal bleeding. Patient was posted for emergency exploratory laparotomy with explained very high risk consent and post-op ventilator support. When the patient was wheeled in for surgery, the heart rate was 160 to 170 per minute, BP 75/50 on NORAD 10 ml per hour and vasopressin 2 ml per hour. Saturation was 98%, cold clammy skin, drowsy, chest clear, urine output about 50 ml per hour, 2 peripheral lines in both the hands, 18 gauge and 20 gauge, right IJV line in situ, femoral arterial line in situ, RT in situ with minimal aspirate. 8 Paxil was on flow. Very high risk consent, including death on table consent, was taken. This patient had a very high chance of crashing on induction. So all the crash cart with all the emergency drugs were kept ready. Defibrillator was ready and charged. The key concerns here were hemodynamic instability due to the massive blood loss, questionable coagulation status, and full stomach due to ongoing bleeding. Anesthesia management was as follows. Pantoprazole infusion had been started in the ICU. 4 milligram ondansetron, Medaz, fentanyl was given, and ketamine 50 milligrams slowly was given. And then vocal cords were sprayed with 10% lignocaine spray. After that, the patient was intubated with 8-number cuffed ETT under vision. There was no retching or no cuffing. The patient allowed the intubation. And then he was immediately put on ventilator on air, oxygen, and IPPV, and 10 milligrams of cisatracurium was given. Intraoperatively, 2 more Paxils, that is the 8th and the 9th one, 3 more FFPs were given, and 1 liter of Ringer lactate was given. 10 ml of calcium gluconate was also given, 50 ml of soda bicarb, and hot air blanket was provided to warm the patient. Surgical findings. A small pea-sized actively bleeding tumor was found in the duodenum, which later on histopathology was found to be a gastrointestinal stromal tumor. The tumor was resected, duodenum closed, feeding jejunostomy done, and surgical time was about 2 hours. As soon as hemostasis was achieved, BP started rising. So intraoperatively itself, vasopressin was stopped and noradrenaline had to be reduced to maintain a systolic BP of 100. APG was repeated, which was again near normal, pH 7.44 with bicarbonates 21.1. INR was still 1.4. The patient was shifted on ventilatory support to the ICU with fentanyl and cisatracurium infusion. At that time, the vitals were as follows: pulse 120, BP about 100/60, and 100% saturation. Post-operatively, 2 more Paxils, 1 cryoprecipitate, 3 FFP, and 1 single donor platelet was given. Within 24 hours, NORAD was tapered down and stopped completely. Serially, D-dimers INR were repeated, which came out to be normal. The patient was extubated on the 3rd day and shifted to ward on the 6th day and discharged on the 9th day. So this is the sequence of events. So almost within 24 hours, this patient had received 11 Paxils, 11 FFPs, and 1 cryo and 2 platelets, single donor platelets. So this patient fits into the massive blood transfusion criteria, which is defined as more than 10 units of Paxils within 24 hours. There are various definitions which are there, but most commonly this definition is used. We can also say that if more than 3 to 5 units are given in about 1 to 6 hours, that also qualifies for massive blood transfusion. So all the possible complications here were of all massive transfusion, that is coagulopathy, acidosis, hypocalcemia, hyperkalemia, hypothermia, lung injury, circulatory overload, multi-organ failure, sepsis, hypotension, anaphylaxis. So all these were anticipated. The resuscitation objectives were to maintain the mean arterial pressure about between the range of 60 to 65, hemoglobin between 7 and 9, INR below 1.5, fibrinogen as 1.522, platelet counts above 50,000 to maintain a near normal pH, and core temperature above 35 degrees. So in our case, the successful outcome was possible because since the time of admission, the patient received a continuous volume support and aggressive ICU management to maintain circulation and control of acidosis. So at all times, his blood pressure was above 75 to 80, and therefore even the urine output was maintained. There was an in-house blood bank, and therefore the supply of blood products was quite prompt. Definitely, it was a multidisciplinary teamwork of intensivist, gastroenterologist, anesthetist, surgeon, and oncophysician. And also the patient was young with no associated comorbidities, so who could bear this stress. These are some of the references that I took. And thank you.
Excellent presentation, Dr. Shagufta.
Thank you, sir.
Very few questions actually. One was, do we regularly do these endoscopies in patients who are actively bleeding on TIVA? Is it better to have a secured airway electively?
Sir, usually there is not, if the patient is hemodynamically stable, we usually do it under TIVA. If there is a hemodynamic compromise, like if the BP is very low, the patient has been receiving a lot of blood, then I think it should not be done under TIVA. But the first endoscopy done here was, at that time, the patient was awake and only slight hypotension was there. So it was done under TIVA.
The point is about securing the airway, chances of
Yes,
aspiration,
yes.
because if the airway reflexes are obtended with mild sedation, or like either the patient is fully under GA with secured airway or fully awake, both are
Definitely,
safe
definitely.
compared to a patient who's partly under sedation with obtended airway reflexes and active bleeding in the stomach. And when you are inflating the stomach, chances of regurgitation are there. That was my question
Definitely.
basically.
Yes, sir, definitely.
So that was one. And like in your laparotomy for when you induced, you didn't mention about cricoid pressure. We knew that patient is actively bleeding. There's too much of blood, and even before that, why the patient was not intubated when the patient was actively bleeding in the
Because
ICU?
in the ice, he was actively bleeding, but actually, see, this whole thing, like the admission of the patient was about 11 o'clock and he was explored at about 8 p.m. in the evening. Continuously bleeding was happening, and it was all means we were not sure how much the patient was bleeding, because there was some gap in between the patient bleeding and then sending the CBC coming back, and there was intervention going. So in the first scopy, they had done clipping and thought that the bleeding was controlled. And then in the second one also, they had injected adrenaline. So it was thought that now there will be no bleeding. But
The patient was continuously on supports basically. So that's why I was asking. If the patient is not maintaining BP and HB is dropping, bleeding actually, then why we
another
did not think
reason
of?
I would say is, sir, this patient had come from village, and his parents were not here, and I think intubation should have been done earlier. You are right. But to put him on ventilatory support, and we had to, yes, I think you're right, sir.
Can I add on?
Yes, sir.
Sir, I'd just like to mention that Dr. Shagupta has done a wonderful presentation, and this is a very neat and tidy presentation by her. And
No doubt of
secondly, the patient was a very close relative of Dr. Shagupta. She was continuously there with the patient throughout the ICU state, throughout the procedure, and almost for 24 hours she was in the hospital in the ICU by the side of the patient. She was like an iron lady, and she took all the decision making, including the anesthesia, including the ICU. All the care was taken by Dr. Shagupta. So she was continuously there with the patient, and she was monitoring the patient continuously. So there's no chance that something wrong could have happened. And secondly, sir, the patient was absolutely conscious until we wheeled in the patient for laparotomy. Patient was conscious, oriented, and the patient was talking as well. So I don't think there was any need for intubation as such in a patient who is conscious oriented and things are stable. Yeah, but patient was hemodynamically was unstable, and hemoglobin was very low. That is the concern. But otherwise, the patient was conscious oriented and everything until the patient was wheeled in for the laparotomy, sir.
You show your face here. Your video is off.
Yes, sir.
One question. How often do you do coag profile, madam, in such cases?
Usually, whenever these patients are posted for endoscopy, coagulation profile has been already done. And I always ask whether this patient has been taking aspirin or any blood thinner. So
No, madam. After all that has happened with hematemesis and the platelets dropping down, after that, how frequently and what all would you like to do?
Ideally, if markers like thromboelastography also should be done, fibrinogen levels should also be done. And actually, the continuously blood products were going. So I don't know how reliable those tests would also have been, because almost his entire blood volume was replaced.
Can I talk for a minute?
Yes, sir, please.
Yeah. So what happens is that we send for these tests, and majority of the times, the fibrinogen levels, which are very important in patients, they come, the picture has changed drastically.
Yes.
That is why I say, means, you send for fibrinogen levels, by the time they come, it is 3-4 hours, the whole thing. By the time you have pushed in probably a whole lot of blood. So the levels which were there earlier are not there right now. So how often we should be doing them, or is it just the clinical picture that finding the presence of clots it's good enough and we stop doing this test?
Yes, sir.
Ashwini, you there? Chat box questions.
We
Just
covered
to add
most of
one
the
more.
questions from the chat box.
Hello?
Just two things. one thing additional as to why was calcium gluconate not repeated in spite of multiple transfusions, and the question was about sodium bicarbonate with a near normal ABG report. What is the role of the 50 ml of soda bicarbonate? Hello, am I audible?
Yes, ma'am. It was given actually empirically because the ABG report was sent pre-operatively, and then before the ABG report, which was done towards the end of the surgery, sodium bicarbonate was given, because we assumed that with the hemoglobin of 3, the patient definitely would be in acidosis because the oxygen carrying capacity is reduced.
Definitely. Yeah, that I agree.
Can I add
Because
something?
because you can't rely on the reports you done pre-op. True. Thank you.
Can I add, Dr. Ashwini? Maybe not for ABG, but for the ongoing hypotension, it
Yes, yes.
justifies the soda bicarb.
Yes, ma'am.
Okay. Yeah, okay. I think that was it.
I can add one thing. Madam, there is no medico-legally death on table concern. We cannot take that.
Yeah, that is true. Yes, yes.
Because it is not admissible. It was discussed in AMC medico-legal issues with anesthesia, the last conference. So we have to take a ill consent, not death on table.
Yes, yes, you are right. But this patient was my relative, and his parents were not here. He had come from village, and I was the person who signed this consent. And it was a very difficult situation for me emotionally also, that I was the person who was responsible for taking the decision, because once I knew that he would be taken into the OT and he would be put on ventilator. I did not know whether he would come back or no. So just for the written purpose, we had just taken this. But yes, you are right. It does not have any medical legal value.
Shagufta, do we have thromboelastography anywhere? Like people say that it is the best and quick results. I have not heard many people using it. That's
Yes, I have also no experience with that.
why. Anybody in the audience, they've used EEG? They could share their.
Do you have a VOC card?
No idea, sir.
No idea, sir.
So all these
So TG is not available in WOCAD as well, sir. No.
Sir, in Apollo ICU, we have this TEG, like based upon the design, it gives a very good graph, like the exact graphic representation of what is shown. Based upon that, we give the platelets if we get that particular thing, and it is very useful mainly for liver ICU. In liver ICU, they have compulsorily a TEG. But I don't think for a general OT or but if it was a patient with CLD with acute GI bleed, definitely TEG would be useful, and based upon that only they give the blood products.
And how much
thank you,
is
madam.
the time lag between the TEG test and the result?
It's approximately, it takes 10 minutes. Within 10 minutes you take,
Within 10 minutes.
10 minutes, yeah.
Yeah, so it is quite useful.
Yeah, in a liver ICU, wherever they do the liver transplant, they have liver ICU, they have TEG compulsorily.
Oh, thank you, madam. Dr. Chandrapriya has joined from Chennai. Thank you for sharing your experience. Yeah. Okay. Any more questions here in the audience?
Just wanted to ask one thing, whether both the scopies are done in the scopy room or in the OT, then it was shifted patient. So was that scopy room was well equipped to handle this kind of emergency?
It was done in the operation theater itself.
Okay, first scopy also.
First scopy also, yes.
Okay, because GI room, endoscopic room is usually is not so much equipped, to tackle this kind of surgery. That's fine.
Yes, yes, definitely.
Thank you, Shagupta. Thank you, Yogendra.
I think most of the questions have been tackled from the chat box. That's all from my side, Dr. Tejveer.
Yeah.
Most questions.
We move on to the next case presentation. We are quite on time actually till now. This is to be presented by Dr. Rahul. One second.
Good evening, everybody.
Yeah. Rahul, do you have your CV?
Yeah.
We did not receive it.
Uh,
Or you could
no,
just introduce yourself.
I'll share my screen.
Yeah, please. Dr. Rahul Ranade is working at Bhaktivedanta Hospital.
Everybody can see this on screen?
Yes.
Yeah. Am I audible?
Yes, Rahul, please continue.
Yeah. Good evening, everybody. I am Dr. Rahul Ranade. I am working as a anesthesiologist consultant in Bhaktivedanta Hospital since 10 years. And thanks to ISA members, they gave me opportunity to present this interesting case and to share this case report with you all. This case is regarding anesthesia management of a bronchoscopy, which got complicated by a sudden massive bleeding and airway obstruction afterwards. So this was like in minutes we were in a adrenaline gush, like a normal procedure getting complicated. So just a bird's eye view of what patient we were dealing with and what was the call. So chest physician gave us a call for elective bronchoscopy. The patient was 64-year-old Indian male, average build with BMI of 25 around. Then he got a chief complaints of chronic cough, weight loss, dyspnea since 2 months, and also urinary tract infection symptoms also. He was known case of bronchial asthma since 4 years, well controlled on medications. He had a stroke, left hemiplegia around 15 years back. For that, left ICS stenting was done, and no neurological deficit was there, complete recovery. And as a post-tubercular sequelae, pulmonary COX he had 20 years ago, he underwent left apical lobectomy also. But in PSC, otherwise he was cooperative, effort tolerance was good. He was maintaining saturation 98% on air. And his routine investigations were like CBC, creatinine, blood sugar levels, ECG, and 2D echo was completely in normal range. For those symptoms, chest physician had ordered chest CT, and which showed a clear-cut consolidation and inflamed area in left middle lobe, suggestive of infective etiology. And he was suspecting a relapse of tuberculosis or aspergillosis or any kind of even the neoplastic etiology also. So he wanted to take a biopsy from that area and also do some bronchial lavage to rule out or to diagnose the situation. So he gave a call of bronchoscopy, and we discussed the matter with chest physician, and he told there was no need of single lung ventilation or lung isolation as such, and no major blood vessels were near that consolidation area, biopsy area. No hyperemia seen on the chest X-ray, CT chest, and minor bleeding was expected. So he was like pretty confident. No, we can do it as a normal bronchoscopy. And we talked to patient also. Patient was very cooperative and calm. And so the primary plan of anesthesia, our primary plan of anesthesia was preparing airway topically by nebulization and topical spray, just as usual bronchoscopy, and a mild sedation first. And then SOS TIVA also, if patient showed some uneasiness or didn't cooperate well, or hemodynamics becomes unstable, then TIVA was considered as a backup plan. Okay, then on the day of surgery, we checked NBM status, we took written informed consent, and we checked OT preparations. Of course, emergency intubation kit and trolley was there, ready. Airway was prepared with 4% lignocaine nebulization and a topical spray of 10% lignocaine. Then 20 gauge IV line secured, standard monitors were attached, IV midazolam, pentazocine, glycopyrrolate, ondansetron, and lignocaine, that is IV xylopart, given. Patient became drowsy and we started with the procedure. So patient tolerated bronchoscopy well initially. As soon as they started bronchial lavage, in many cases, patients started coughing and little short of hemodynamic parameters. So we added with IV propofol, some IV ketamine, and IV dexmed to suppress the hemodynamic response and to further ease the procedure. So bronchoalveolar was done uneventfully, and he went for a biopsy. Biopsy was taken from that consolidation area, a very small chunk of biopsy he needed. As soon as he took the biopsy, sudden bleeding started from that area. Initially, it was very minor, so he tried to infiltrate 1:100 diluted adrenaline, but there was no response of adrenaline infiltration. And as within a minute, the blood started gushing very profusely, and in front of our eyes, within seconds, it filled up two bronchi and whole trachea, and patient started violently coughing, and frank hemoptysis was evident. Obviously, we were on toes now, and we went to further step of escalation matrix, and we did pharyngeal suction, gave patient IV propofol and IV Zolocard, and intubated the patient in as an emergency basis with 8 millimeter of 8 number PVC cuffed Cortex 2. And then here pulse rate was around 122. SpO2 dropped within to 70 to 60 percent. BP was shot up to 150 to 90. So we first gave IV labetalol simultaneously, IV propofol and IV Zolocard, just to suppress the hemodynamic parameters and to increase the tolerance for the tube and to assist intubation process also. And continuously we did endotracheal suction. At that time, we were not, we were more concerned about the asphyxia or ventilation kind of ventilation matter, and not of aspiration as such, because blood, whatever blood was coming, it was coming itself from the lungs. So we continued ETT suction for a minute. Within seconds, there was no active bleeding, and we got our window of the clear ET tube, and so we started mechanically ventilating the patient. And there was a demon in front of us that extreme high pressures were required to ventilate the patient. The machine couldn't give the required volume at the 40 max pressure. So we hand ventilated the patient. The bag was stone hard, and there was absolutely no entry on the left side and a very feeble air entry on the right side. And pressures were like 40 to 45 centimeter of waters. SpO2 dropped to 65%. Tidal volume was barely 100 to 140 ml. I am still exaggerating here. It was sometimes 50 to 60 ml also. And ATCO2 at this kind of volume becomes unreliable. So, but still, better than something better than nothing. We continued the ventilation for 1 to 2 minutes, and saturation improved to 90%. Heart rate and BP was settled, but ATCO2 we couldn't comment on that because the expiratory volume was so less that it's supposed, it's assumed that hypercarbia is there. So we were now concerned with the hyperventilation and resultant hypercarbia with extreme high pressures, and it demanded immediate screening of airway obstruction. That kya ho raha hai andar? What is the what's there beyond the endotracheal tube that's causing some obstruction? So again, the bronchoscopy was done, and there was another demon sitting right at the distal end of the endotracheal tube. There was a large blood clot at the carina, extending its both arms into both main bronchus. Right main bronchus was there's some mistake. Left main bronchus was completely occluded, and right main bronchus was partially occluded. And distal end of the endotracheal tube was above, means almost inside the clot, you can say. And so now, obviously, in such situation, the gold standard care is to obtain a rigid bronchoscope and remove the clot. But just to note, that patient was a VIP ISKCON VIP patient. So at that point, two things came at the moment: Murphy's law and the VIP syndrome also. Our rigid bronchoscope available in setup was under repair just a few days before. So there was no rigid bronchoscope available at our hands. So we, though that chest physician called his friend to mobilize the rigid bronchoscope, he was 15 kilometers away from our hospital setup. So in this type of desperate scenarios, situations, 15 kilometers is like 15 light years. So we couldn't rely on that. But we also thought about Fogarty, but the problem of Fogarty in this such scenarios is to extract the obstruction, Fogarty has to be reached distal to the clot, and then you can inflate the balloon and you can pull. But here it was like Y-shaped clot, and there was no way to find out that where Fogarty is heading and where is the distal end of Fogarty. If in between midway, if we inflate the balloon, clot may rupture. Distal end of the distal part of the clot may push more distally, and the whole scenario will become fuzzy. So now we were in the soup. Now it was like a stalemate, a desperate situation which demanded immediate intervention. So, but it was like thanks to our fraternity, that thanks to our exposure to many different kind of endoscopies like GI endoscopies or urological procedures, that it came to our mind that yes, there is a instrument called as Dormia basket, which usually urologists or GI endoscopists use to retrieve foreign bodies or stones or coins or something. So, and the diameter of Dormia basket, I knew that it can pass through flexible bronchoscope. So we suggested, and the main specific thing is you can open the Dormia basket inside the clot also, so that it will grasp the clot at its neck, and we can pull it out. So means that was our guesswork, or that was our hopes. Those were our hopes. So we suggested chest physician to use the Dormia basket, and who happily accepted the advice. And he tried to retrieve the clot, and he successfully retrieved the whole clot at once after 3 attempts. As soon as a clot was out, there was immediate decrease in airway pressures. The pressures saturation improved to 96%. Peak airway pressure was around 20 milliliter of mercury, 20 centimeter of water. Tidal volume was around 450 to 500. That is normal tidal volume. Heart rate and BP got settled. Then we also auscultated the patient. There was a minor bronchi, but there was pretty nice air entry bilateral lungs. So, and then we also inserted the bronchoscope further, and there was no active bleeding at the biopsy site. So basically, chest physician was happy, and we were also happy. So then, basically, whatever the aims were, they were almost means he had done a bronchoalveolar lavage. He had taken a biopsy. There was no active bleeding at the biopsy site. So basically, the procedure was complete, and he removed the bronchoscope. We of course shifted the patient to the ICU on positive pressure ventilation. Some more IV propofol, dexmet, and xylopod was given to enhance the ETT tolerance. And because we needed to shift the patient to the ICU with the secure airway, because there was always a chance of recurrent bleeding from the site, and the protected and secure airway was better. And also we were under impression that there might be some atelectasis changes or pneumonitis changes. So, so we shifted the patient on the AT2. So the aftermath, that biopsy revealed aspergillosis. So antifungals were started. A patient got extubated after 24 hours. It was uneventful. No further bleeding for the airways confirmed. Post-operative chest X-ray didn't show any atelectasis or pneumonitis signs. Patient didn't have any awareness or recollection of events related to the procedure. Patient was discharged after 6 to 7 days and went home with happy face. So you can see this is the clot, and just to get the size, I have given the Dormia basket's size 3 by 6 centimeter when fully open. So size of a clot is, it's a Y-shaped clot, and around 12 to 16 centimeter of the clot is there, and it was two arms were occluding two bronchuses, and this main portion was occluding a trachea. So basically, conclusion and take-home points are like we should be adaptable, and we should have flexibility to use cross-disciplinary tools in necessity. And we should anticipate the bleeding in lobectomized, aspergilloma affected, and post-TB lungs. And whether to believe on your physician or surgeon, it's your individual tech. But of course, you can means presence of mind can save the day at that time. Team readiness and rapid decision making also make the better outcome. And I thank to Dr. Kshama ma'am, my HOD, who helped me and guided me in the entire process. And with her help, we could sail through the situation. And, it was I went through the literature also. Incidence of such massive airway bleeding during flexible bronchoscopy in different series is 0.26 to 5%. Of course, the standard of care is rigid bronchoscope. But if it was our luck that bleeding was stopped because of active clot pressure itself. But if bleeding had not stopped, then the isolation of the lung, that is one lung ventilation, bronchial artery embolization, and cryoablation were the options. But in our setup, it was not, on the horizon at that moment. So Dormia basket use was the innovative kind of suggestion given by anesthetist to the chest physician. So it came as a rescue kind of thing. So it was used before also in flexible bronchoscopy for bullet retrievals, clot removals, and nuts and seed removals from tracheobronchial tree. So basically that's all. Thank you all for patient listening, and thanks to our cute Dorme basket. Thank you.
Thank you, Rahul. It was a very nice presentation. May I have some comment from Kshama Madam? Madam had raised hand, so I thought she's ready. Okay. Till then, there are very few questions actually here. It was a very high risk case, very well managed. Is it our responsibility? One sec. Kshama Madam, you can unmute yourself. Is it our responsibility to see that?
Am I
Yes, ma'am.
audible now?
Yes, ma'am. Please.
A very
Please go ahead.
good evening to everybody, and I thank BSA team to give us this opportunity to present our case done here, our experience. So yeah, it was a nightmare, and we are having very high pressure. So this repeatedly asked question during Rahul's presentation is that was the muscle relaxant was given. So answer is no, because we were not able to ventilate the patient properly. We did not know what we were heading to. So we were giving arbitrarily bolus doses of propofol so that patient doesn't have awareness. At the same time, patient was not fighting or moving too much, So giving relaxant and seeing the clot obstruction in front of us. So that was a very scary situation. So we did not give any muscle relaxant. Afterwards, when patient was admitted, shifted to ICU, he was kept on fentanyl midazolam infusion for ventilation, and he was fine with that. Yeah.
Yeah. This was just one question in my mind, whether it is our responsibility to see that whatever instruments might be required, like for example, rigid bronchoscope in this case. Is it our responsibility to see that it is available?
Yeah, we should, according to Rahul, we should, according to, after this experience, I think we had done many of bronchoscopies before, and chest physician said that it will not bleed so much. But when we went through literature, we found that this query aspergillosis fungal infection, if it is suspected, they are bound to profusely bleed. So in that case, yes, we should have been. But rigid bronchoscope was available to one of the friend. Now that person of our
Ma'am, you're not audible.
I have unmuted myself.
Yeah. Now we're audible. Now we're audible.
As Dr. Tej asked this question, whether rigid bronchoscope is our responsibility. So our chest physician was very, very confident that nothing will happen. Thoda biopsy leke मैं बाहर आ जाऊंगा. But later, so we obviously believed them and we gave the sedation. But later on, when we went through the literature, we found that this query aspergillosis fungal infection, they are bound to profusely bleed sometimes. So we have learnt a lesson through our bad experience. Yes. Definitely that. Dr. Rahul, you would like to say about the DLT part?
It came to our mind that we could have used the DLT, but the technical problem was the DLT's lumen is not that much compatible with the adult flexible fiber optic bronchoscope. It can pass through the DLT, but then again taking a biopsy and BL avage from the DLT becomes a technical challenge. And for that, you will need a pediatric fiber optic bronchoscope, and that was not available in our setup. And basically, so the bleeding part was quite not expected as such. Means, and usually we do BL lavage and bronchoscopy in under TY and sedation only, so we don't consider the thing. And biopsy was it was a minor kind of biopsy. So, but yeah,
That
whatever
is what physician,
happened.
chest physician said. For him, it was minor biopsy. Now I
Yeah,
think he will.
Yeah,
He
it is always
also.
minor.
it was
We all
chest.
learned.
It was
We all
chest
learn
physician's
lessons
opinion that it was
sometimes
minor.
through our bad experience. We
Yeah,
have sometimes we feel that all the things are written in the textbook, and if we have not seen, it will not happen. But then over the years, we see many complications which are written in the textbooks, and then we
yeah,
become more cautious next time. That's a lesson we learn.
yeah.
It is always minor till it becomes major.
Yeah.
Can I
Yes, sir.
talk?
Please, sir.
Yeah, only thing is that if you were at a place where the saturations were not picking up, at least you could ventilate the right lung, forget about the clot, and get the saturations up with the DLT is what is possible, I feel.
Yeah.
Or it would not be possible to insert the DLT ऐसा situation था क्या?
नहीं, afterward it's not possible. अगर करना है तो पहले से ही isolate करना better है.
That is it. Because once a patient has bled so much, and then now we came across this high pressures, then we did not know what we are dealing with. And
No, but you had a
DLT
bleeding. You had a bleeding coming from the left bronchus. The right side was reasonably good.
No, sir. That if you
clot was seen at the carina only.
Okay.
bleeding spilled over the both bronchuses. That is, first it filled left, then it spilled in the right bronchus. That's why you can see in that blood clot, the shape of blood clot is like a Y shape. So once that clot is formed, it was impossible to insert the DLT. So if whether DLT का option है तो मतलब पहले से ही डालना better था.
And for if you want to put DLT at that stage, you have to be really expert doing it, and you have to be like very frequently putting DLT and very confident about it. That is also there, putting DLT in that at that stage.
Yeah.
Okay. Dr. Ashwini, chat box questions.
I don't see any questions in the chat box. There is just one comment, they're really complimenting example of an anesthesiologist thinking out of the box can actually, help such situations. That's it in the chat box.
Yes, Dr. Rahul thought of that कि चलो डॉर्मिया बास्केट जो है सामने वो तो पहले यूज करो, बाकी सब बाद में आएगा, वो होएगा.
Can be saviors for surgeons, proved once again.
Yeah.
Rahul, these minor, so-called minor cases, when it has a major complication, how do you handle the relatives? There's a question on that also. How did you explain the complications and
it is
possibilities to the
combined
relatives?
job of that is along with chest physician we talk to the relatives. We told them ki, what happened, that bleeding was not expected and biopsy was minor, but as a 1% to 2% means rare complication, it has happened and we have tackled over it, and that's why we have, for safety purpose, patient's lungs are now okay, but we have shifted him on ventilator just to be cautious and to observe that that area is not still bleeding or will not bleed in that's all.
And this was done after handling the patient.
Yes.
Yeah,
yes.
but
After everything
basically this handling or relative was not a big problem for us because this person, as
Was known.
Rahul said, he was ISKCON VIP. I knew him personally last 35 years, and many senior doctors of Bhaktivedanta know him, and we are like family members. So everybody was there. Our CEO was there because he's VIP in the OT. Now what is to be done? So it was like we are brothers sisters. That was the scenario, to do the best, and God did best for him. That is, God saved him,
ma'am,
us also.
this severe kind of bleeding, which was almost life-threatening, it stopped on its own without any active
Yes.
intervention.
That was our luck. That was our sheer luck.
I mean, that was
Maybe
a
because
godly
of
intervention, probably.
yeah, yes, maybe because of the clot itself did the job.
Yeah, because otherwise, when you remove the
Because of
clot, it might have just.
Yeah.
Because of clot, the coagulation profile was okay. Your profile was also okay.
Yeah.
Yeah.
Thank you, everyone.
Thank you.
Very nice case, actually. Very challenging case. We move on to one more challenging case. This will be by Dr. Abdul Kulkarni sir. He's a very senior consultant anesthesiologist. He has his own hospital, Sterling, and he is also attached to a few more hospitals, practicing for more than 35 years. It's a case of use of dual epidural catheter in a high-risk patient. Sir will take over now. Thank you, sir.
Yeah. Good evening, everyone. I thank BSA for having me to present this. So this is a very COPD patient with a liposarcoma on the back. I have been regularly working with this surgeon, and we have had patients who had bad breast tumors. We have done rotation flaps even under epidural where high-risk patients were there. So this patient was a 65-year-old male, known COPD, presented with a big liposarcoma on the back. Now, excision of this liposarcoma and with a myocutaneous flap, which would be a latissimus dorsi flap, which would raise from the whole from the ASIS to this level. So it was a very big flap. Now, this patient had gone to a couple of hospitals, and that said that looking at this PFTs, he was a COPD with a FEV1 of about 1.2 liters, FVC of 3.5 liters, the ratio of 34%, PFR was slightly okay, but it was a mixed restrictive and obstructive picture. So two hospitals, they said that we have to give GA, put you electively on ventilator, and we don't know when you will come out of the ventilator. I was quite scared. So my surgeon asked me, can you do without intubating him? He was more confident than me. So I thought of it that we have a epidural, which is a reasonably good analgesia. Now this is a surface surgery. This is not a deep surgery. I don't require too much relaxation. But epidural is kind of, segmental block. So one epidural catheter putting at suppose say T7, T8 would not cover probably the whole area from T1 to T12. So I thought of putting two epidural catheters, one high thoracic, one high lumbar. And I told the patient, if this works, it's okay. One plan A is we put a thoracic catheter and lumbar catheter. We at least excise the tumor. If a second epidural doesn't work, we for some time, and second we will go in and put a second time we'll go in do the flap. And B was to give GA. If we were started with the flap and the patient was operative. But patient was highly motivated, and he really was very cooperative during the whole procedure, which lasted almost 5 hours. So we monitored the patient pulse, blood pressure, saturation, ECG, nasal CO2, temperature, and air warming device. So we put two catheters. One I put at about C7T1, and second one I put around T12L1. So this was the full defect. It was, I casually asked the surgeon, can you reduce the defect a little bit? He said, not possible. This we can't reduce by doing any plastic surgery. We have to compulsorily go for the flap. So catheter 1 we activated first. We gave 10 ml of 0.5% bupivacaine with 10 microgram fentanyl. And another one hemodynamically, patient was stable, another 2.5 ml. Patient was put in lateral position and they excised the growth. This took about 1.5 hours, that is about 1.5 hours. Now, once the excision was done, we activated catheter number 2, where we gave 10 ml of bupivacaine, 0.5% with fentanyl 10 micrograms. And we kept on repeating 5 ml every 1 hour, 15 minutes, 1.5 hours. So this was the whole excision. It was almost from ASS till the T1. So the whole incision was exposed at one given time. And this was the picture at the end of the surgery. So what were the challenges? Were the tolerating the position. Patient was very motivated, and we supplemented some sedation. We gave Dexmed at the induction and every 2 hourly. And we gave a low dose fentanyl midazolam after induction and nasal oxygen nitrous prongs at 2 liters per minute. Only once while doing the flap, he had little escape pain, which we covered with ketamine. He had a little bit of nausea in the middle of the procedure covered with metoclopramide, and blood loss was around 400 ml. He was observed in ICU for 1 day and discharged after 5 days. So epidural being a segmental block, we could take advantage of that and do the surgery, and it was on different dermatomes. So luckily we got a period of about, I mean, the surgery was not 10 years, so we didn't have to flood the patient with too much of local anesthetic. We could give 10 ml, and then subsequently second catheter we could give 10. It was a surface surgery. Another thing was that the whole procedure was done in lateral position, so patient needed to be cooperative, but he was very motivated, and intermittently we kept on asking him whether he was comfortable, and he was quite so. There have been 2-3 references where they have used dual epidural catheters for patients where they wanted to do opioid sparing anesthesia. But these are mainly for analgesia after the surgery. So one was for spine deformity and 2 were for cancer surgery abdominals, where they used 2 epidural catheters, and they practically did a opioid-free anesthesia and post-operative period. Thank you.
Rao sir, any comments? Rao sir was here just now. Okay. Sir, about this wonderful case, I mean, we heard it for the first time. At least I heard it for the first time that this also is a possibility. What was the total duration of surgery, sir? Right
5
from
hours. 7.5 hours for excision and about 3.5 hours for the lat dorsal flap. So total 5 hours.
And the dose that you mentioned was nowhere near the higher, I mean, the upper limit. So I think everything was.
So we had to subsequently give the dose of the big advance. No, we had to simultaneously, we had to do it, probably the dose would have been higher. But it was excision, and then subsequently we had to go in for doing the lower part was a big advantage to us.
And when the flap was brought up, rotated, or whatever the closure, you required both the areas to be anesthetized that time?
The upper part, no, surprisingly, upper part, few sutures they took, they didn't require much to be given. Whatever we had done was enough.
Okay.
May I ask something?
Yeah.
May I
Yes,
ask
sir,
something? You said it was a sort of segmental spinal.
Segmental epidural.
I'm sorry, epidural. So you used isobaric or hyperbaric?
No, routine epidural. We use 0.5% UPV, whatever vial we get.
Not isobaric.
No.
Acha.
Routine. The 20 ml vial we get 0.5% UPV in that way.
Yeah, regular. Hello, may I say something?
Yes, sir. Yes, sir. Continue.
In past, about maybe 20-25 years back, 130 kilo orthopedic surgeon was operated for abdominoplasty and liposuction. He was done with 2 epidural catheters. One was going up and one was going down, So that area was covered from thoracic T10, about T10 to down. So I'm just got reminded of the case which was done by some other anesthetists where I attended the surgery, and 2 catheters were used. One was going up and one was going down.
So this is also the way you said it has been described for labor analgesia, where they have tried to 2 catheters, one going up and one going down.
Yeah.
Especially for second stage of labor, they said downgoing catheters have been useful.
Correct. And you used which direction? One was going up and
both upwards.
Upwards only.
Yeah. I have been routinely doing MRMs under cervical epidural. That is
cervical epidural. Correct.
Yeah.
There also you put up.
I have done more than 50 cases up till now, and that is the standard. Put 3 centimeters inside C71. I'm very comfortable with that.
Up only. Both the
Up,
catheters
both
are up.
both catheters upwards, of course.
Cephalic. Okay.
Yeah.
Yeah. Good. Very nice.
Yeah.
Sir, one question
And
by Dr. Naresh Paliwal.
yeah,
Yes, sir.
What would be your plan if accidental dural puncture would have occurred?
Sir, I am not comfortable giving spinal at cervical level. Not comfortable. I would have gone one space lower down and put an epidural again.
Sorry to ask, thoracic, you said thoracic and lumbar you put.
Yeah.
Catheter. Yeah.
Hello.
Not here, not.
Hello.
I number T12 L1.
Okay.
Hello. Can I add?
Yeah.
yes, sir.
If you get an accidental dural puncture, not at the cervical level, but at the thoracic or even at the lumbar level, why not convert it to continuous spinal? That is the best option in such case, rather than going at other space. And what happens if the patient again gets accidental dural puncture?
I have not
Continuous
done
spinal can be a
spinals, sir.
best option for such a case. You can use any drug you want. You can use isobaric, hypobaric, hyperbaric according to need. You can use low concentration, high volume that can produce a segmental block, which can be better as compared to your segmental epidural.
Okay. I have not done many continuous spinals, sir. So I was not.
That's one of the options when you get accidental dural puncture. You can better convert it to continuous spinal rather than going to another space. In such patient, this can be the best option.
Okay.
Because there you can have any other option, like for upper surgery, you can keep the patient head up, give a isobaric, hypobaric drug that will cover the upper segments. You can change the tilt of the table, you go lower down. You can do anything with catheter in place, and number of options.
Here, sir, we had a patient who was in lateral position.
Yes, in lateral position, you can use isobaric or hypobaric drugs, which can provide you a better hemodynamics, as well as being a superficial surgery, you don't need much of a relaxations.
Yeah, exactly.
So adding just fentanyl to your isobaric drugs can create it hypobaric, and that will act on the non-dependent side.
So, sir, for this, suppose there was an accidental puncture, how much local anesthetic would you put intrathecally?
Initially, they did a excision of that tumor. So I'll keep the patient slightly head up, just 1 ml of the isobaric and half cc of fentanyl. That will work around 1 to 1.5 hours. Only the upper side, which required space, will be blocked. And then while in this floss, you can use anything. You can use low concentration, high volume of hyperbaric or isobaric drugs. Not hyperbaric, but better use isobaric drugs. You can choose a lower concentration, just 0.25% can work.
Because we don't have
dilute it with
relaxation.
normal saline, it can spread to wider segments, blocking both upper and lower levels. Only single catheter can do at both places. Now, the another option is you can use segmental spinal along with your epidural.
So I think for lower punctures, probably we could think of this.
And directing the catheter lower down is usually not recommended to avoid the cauda inguina syndrome, because local anesthetic gets stuck up in the caudal space, and that can create cauda inguina syndrome. So what you have done is right. The catheter should be directed always upwards, not downwards.
Another thing, sir, since we are discussing this, because the lower part was later on. So initially, I would suppose, say, hypothetical situation where we are giving a spinal. By the time we finish the excision, the lower part, the spinal would be over, or you feel electively put a intrathecal catheter, it would be working better.
Intrathecal catheter would have worked anyway, because you have n number of options in the drugs. You can use isobaric, you can use hypobaric, you can use low concentration, high volume of isobaric drugs, which can cover wider segments without any hemodynamic compromise and respiratory issues. Even if you give higher, just 1 to 1.5 ml of the drug, dilute it to twice, and it will spread to the wider segments, just giving you a superficial block. I mean, mostly a sensory block, not involving the motor, this thing.
Thank you, sir.
Sir, there's one question. Was there any technical difficulty in introducing the cervical catheter because it was very close to the lesion?
No, lesion is away.
I mean the fixation part and the.
No, I have shown you how I sit. Again, I can show you if you want. We fix it with tegaderm, both the catheters. See, this is the way we had fixed the catheters. We had put a tegaderm here, which is coming up to here, and swelling is away. And even after excision, the catheter is nowhere nearby. So we shade it on the other side.
Okay, sir. I think that's it with the questions. Thank you very much, sir.
Thank you.
We actually came to know one more idea to be used sometime in future if we get a similar case.
Thank you, Tej.
Thank you, sir. We move on to the next very interesting thing case. Dr. Renu Raka, who is a consultant anesthesiologist in prior practice for last 9 years. She is presenting something that we don't see regularly. I let her talk about the case. Renu, please.
Am I audible, sir? And is the screen visible?
Yes, you're on. Yes, it's visible.
Yeah. Good evening, everyone, and thank you, ISM Borivali, for this wonderful opportunity. So after hearing to the challenging cases inside the OT, and most of them were like an emergency things inside the OT, we are now going to go to a elective setup in a subset of patients who are challenging patients because we are not used to doing those surgeries. So, my screen is not visible.
It is visible.
It's not visible to me.
If it is not visible to you, you can reshare it. Stop sharing and reshare.
Yeah, now it is visible. What I am going to discuss here is the existing data and guidelines available from across the globe for providing care to individuals seeking gender affirming care, and in short, how I do it. Gender dysphoria is defined as a sense of discomfort or distress in individuals because of incongruence between the gender assigned at birth and the preferred gender by that individual. The symptoms should last for at least 6 months. And some people who identify as transgender do experience gender dysphoria. The symptoms can begin as early as 9 years of age, and they are most commonly seen after puberty. They cause significant impairment in social and occupational functioning. Whenever there is a person seeking gender affirmation, the individual goes through transitions. For example, social, legal, medical, and surgical. In social transition, they change names and the way of dressing. Legal transition is their names and name and photographs are changed on the government IDs. Medical transition is done by the endocrinologist, where they start gender affirming hormonal therapy and GnRH analogs for suppression of puberty. And surgical transition, which is an irreversible process, feminizing and masculinizing surgical transition. So this is the point where we come in contact with these individuals. So what are the gender affirming transition surgeries? Cosmetic surgeries like face and neck surgery, mandible reduction, chin augmentation, hairline advancement, rhinoplasty, tracheal shave or chondroplasty, voice altering surgeries, which I'm going to discuss in detail, mastectomy or breast implants, and surgery in the genital area like vaginoplasty and phalloplasty. The other surgeries which are not gender reaffirming, but these patients do undergo are hysterectomy, uterine transplants, and ova preservation procedures. When they go to an endocrinologist for medical transition, usually they are put on hormonal therapy, which include testosterone, spironolactone, estrogen, bicalutamide, and cyproterone acetate. All these drugs have, because they will be on these drugs for a long time, like probably for lifelong, they will definitely have some effects, which are the side effects of these drugs. For example, testosterone can cause QTc shortening, erythrocytosis, increased risk of myocardial ischemia, obstructive sleep apnea, and hypertension. Estrogen can cause increase in weight gain, increased risk of venous thromboembolism, stroke, myocardial infarction. Estrogen causes decrease in serum albumin, so there is increased level of protein-bound drug. So the free levels of bupivacaine will be higher. Decreased level of plasma cholinesterase activity, so expect a prolonged block with succinylcholine, and increased incidence of post-operative nausea and vomiting. With spironolactone, there will be renal damage. With bicalutamide, because it's an liver, it is metabolized by cytochrome P450 and it's an enzyme inhibitor. The serum levels of midazolam are increased if the patient is on this drug, and cyproterone acetate can cause adrenal suppression. Let's go to the vocal pitch altering procedures in detail. Voice feminizing surgeries, what happens, they decrease the size of the glottic opening by approximately 33%. So it can be endoscopic or open glottoplasty, or they create a web in the vocal cords, which can decrease the glottic aperture. So this decreases the pitch of the voice, and so we have to select a smaller size of endotracheal tube. Laser-assisted vocal cord reduction is done, which causes scarring of the vocal cords. So there is difficulty in passing the tube during intubation. And the most dangerous is cricothyroid approximation. Sometimes this may lead to complete loss of the cricothyroid membrane. So in preoperative evaluation, we have to ensure which procedure is done and see for the front of neck access, if we can do it with a CT membrane in the PAC itself to avoid because if CICV situation arises, we should have a front of neck access plan, alternative plan ready. Voice masculinizing surgeries, most commonly thyroplasty type 3 is done, and again, in such patients, we have difficulty in passing the tube. So if the patient has undergone vocal pitch altering procedure in the recent past, we should avoid elective surgeries for 8 to 12 weeks post-op. For emergency surgery, we can use regional or local anesthesia in such patients. If you have to give GA, try using a supraglottic airway device. And if intubation is necessary, we should use a microlaryngeal tube with an internal diameter of 5 or 6 mm. So these patients usually will come for preoperative evaluation. This is the most important step of managing anesthesia for a transgender patient, because the history is very important. And this is the first time you will come in contact with varied symptoms. Some people will be on hormonal therapy. Some people will have a history of undergoing other surgeries in transition. They might have suicidal tendencies, anxiety, depression, substance abuse, even schizophrenia. And few have history of autism in the childhood. So autistic individuals have more incidence of having gender dysphoria. So in the preoperative evaluation, one aspect which I would like to highlight here is that we should respect the chosen name and pronouns. This area is we are a little unaware of this, because even socially and academically, we are not used to dealing with such people. So we have to learn the terminology if we are dealing with them. And you record the gender assigned at birth and the gender preferred by that individual, both in your PAC sheet. Review hormonal therapy, we just saw that they have various side effects, and document the medical surgical history and screen for mental health issues. Ensure psychological safety of the patient, ensure privacy and dignity in the perioperative period. Misgendering can cause distress. Initially, when I was dealing with my first patient, I had a very tough time, because when you see a patient who is gender assigned as male at birth, who looks like a male, you tend to, call him a male. But you have to learn how to deal with them, because misgendering can cause distress. train staff on gender affirming care, and screen for perioperative anxiety and dysphoria. In the preoperative assessment, airway assessment tools might be unreliable because of the cosmetic procedures of mandible reduction and chin augmentation. For example, thyrometal distance will be altered and you won't be able to judge the difficulty of intubation. Trans men usually use chest binders, which can, and they use it for a long time. So it can cause restrictive lung disease, and this becomes significant if you have a surgery in prone position. So you have to ask them to remove the chest binders and do a PFT if required. Testosterone can cause laryngeal hypertrophy, and as I discussed that these patients are more prone for obstructive sleep apnea, but the stop bank questionnaire is inaccurate for these patients. Because of the hormonal therapy, there are cardiovascular changes. There is QTC prolongation, STD changes also, hypertension, left ventricular hypertrophy occurs. They are at risk of ischemic stroke, MI, venous thromboembolism. So all these risks are more if they continue the hormonal therapy in the perioperative period. So you have to discuss, generally the surgeon and the patient already have discussed this. They discuss whether to continue the hormonal therapy or discontinue before 2 weeks before surgery. So the World Professional Association for Transgender Health, it suggests against the discontinuation because there is a risk of exacerbation of dysphoria. But in India, we discontinue the hormonal therapy 2 weeks before to prevent any increase in the risk of thromboembolism. This is usually routine pre-op lab workup is like any other surgery. What we do is we add thyroid profile and blood sugars and 2D echo and venous Doppler of both lower limbs. Airway evaluation if the voice altering surgery has been done, an ENT checkup and an ideal if necessary. If you're not able to perform an ENT checkup and ideal, CT neck would help to know the condition of vocal cords. So after PAC or during PAC, you have to ensure that the patient has a certificate by a psychiatrist. The SOP by Union Health Ministry of India suggests that before starting endocrine treatment, that is medical transition, a certificate from one psychiatrist is required, and before irreversible surgery like gender affirming surgery, 2 certificates are required, one from a psychiatrist, the other one either from a psychiatrist or a psychologist. Intraoperative consideration, I'm just going to highlight the points which are different from normal patients. After 3 to 6 months of gender affirming hormonal therapy, you can use ideal body weight of affirmed gender for drug dosing, ventilation parameters, and creatinine clearance. The use of TIVA and TCI pump is because there are no TVI TCI models for this patients. Use of EEG is mandatory if you are going to use only TIVA. We use mechanical and pharmacological thromboprophylaxis for all major cases, that is surgeries lasting beyond 4 hours. And you have to bear caution with transfusion because previous samples and previous reports might have different name and gender. So it's ideal. What we do is we take blood sample on the day of surgery again, and I check the label myself for blood group and cross match if it is going to be required. Post-operative considerations, pain management according to the surgery. Be aware of altered anatomy for urinary catheterization. Restart the hormonal therapy once stable, and post-operative thromboprophylaxis continues until the patient is mobilized, and monitor for psychological well-being. The key takeaways are provide respectful patient-centered care, understand hormonal therapy, prepare for a unique anatomic and physiologic variations, and promote a culturally competent environment. Here are a few references. Thank you.
Thank you, Dr. Renu. This was a eye-opening kind of thing. Never actually seen it. So it was more of theory for us, but then there are a lot of things that we don't know. That's what we realized. So yes, thank you for
May-
that. It's a very informative
May I,
session.
Thank you, sir.
may
Yes,
I share my experience?
Yes, sir. Please.
Just 2 minutes. Madam Renu covered so many other things. I
Yes,
had a chance of practicing with a plastic surgeon, and we did almost about 15 cases of sex change.
okay, sir.
It so happened, among all the investigations you mentioned, but
Yes,
the thing which I noticed that has not been mentioned specifically. Here was a case of 25-year-old male who came for sex change. He wanted to become male to female.
yes,
I may not be talking about all scientific thing, but this is what happened. I'm in a reality. So the surgeon, plastic surgeon, is a good friend of mine. He said, Ashok, all the investigations I have gone through, they all are fine. And we posted the patient on particular day at particular time. So I went in the morning, about an hour before the surgery, and clinically examination is absolutely fit. And I went through the investigation, our CBC, blood sugar, hormonal things, this, that, X-ray chest. But back of my mind, because this was the case of male to female, I was all the time thinking about HIV test.
yeah,
That is very important. So
yes,
when
sir.
I saw the report, it was non-reactive, but I specifically saw the name of that patient. And let me say the name, this was different name, but something like his name was James, say. And all the papers had James' name on. But this paper was of Jesa. Normally, we don't see the name of the patient when we go through all the investigation. So specifically, when I saw that it was a non-reactive, but the name was of Jesa. So that created a doubt in my mind. So I talked with the surgeon, friend of mine. I said, some fishy thing is here. He said, okay. So we asked him, the patient. Initially, he said, no, I am not positive HIV. We said, okay, we collected the blood and we sent it down into pathology. And we were having a cup of tea in the doctor's room. Immediately that fellow said, he is strongly positive HIV. Don't do the surgery. Then we asked him, he said, yes, I am positive, but I don't want to reveal it to anybody. So we gave him an option that we will put you on medication, in future you come. He said, no, whatever amount of money you want, you take from me. I am ready to give you. We did not do the surgery. He went somewhere and must have got it operated. What I just want to say is, all this transgender, it so happened once I did one patient, the same patient came after 2 or 3 years, not the same patient. Another patient we operated from female to male. And that came for appendectomy. So first thing he said, he saw me, he said, doctor, kisko mat dikhana.
Urine pregnancy test.
Don't tell anybody that I undergone this sex change surgery and all. So that thing you said, right, that is very important. Mentioning he or she or it, sometimes, that thing comes in our mind. But then we have to play research. But just looking the reports and the name of the patient is very important.
Very
All
important.
this patient. Yeah. Okay, thank you.
And plus, more
Sir,
thing,
I missed it.
nowadays it is, I think, mandatory to take consent for HIV testing. No, most of the hospitals, they have a form where you require consent for testing.
I know this was at a private nursing home. So he came with the reports, but the name was different. That is, actually, it came to my mind. I said he could be HIV positive because male to female. So this is what happened with me. This is I wanted to share with you. Okay.
Thank you very much, sir. I had missed about the triple H. Definitely, it is very important.
Very important. Very important.
Yes.
Thank you,
Sir,
sir.
I would also.
Yeah, Renu.
There is one more thing. The international guidelines suggest that we also offer them urine pregnancy test when they are coming for female to male transition, because they have the
Pregnancy
uh,
test.
the pregnancy test.
Yeah,
For
always.
but yeah, so I had missed that also in my presentation.
Yeah.
Yes, Renu, wonderful
Can I ask
presentation.
one question?
There are not many. There's actually no questions in the chat box. People are just in awe of
I
your
wanted to ask
presentation.
one question.
Yes, Sandeep,
Yes,
please.
please go ahead.
Renu, excellent presentation. Just wanted to ask, what are the legal implications that I should know if I come across such a patient for surgery?
So
Any
yes,
legalities involved?
yes. So the national SOP by Union Health Ministry of India is now changed. Previously, before 3-4 years, we used to take an affidavit. We used to ask them to make an affidavit, and we used to wait for their government IDs change and everything. After that change only, we used to go ahead for the irreversible surgeries. But now the regulations and laws are like that you don't need a affidavit or anything. You just need clearance from 2 psychiatrists and that is in the past 6 months. The report should be within last 6 months to undergo the surgery. So legally, it is a legal procedure, and there are no other things required. Only two certificates from 2 different psychiatrists for clearance.
May I add something to this?
Yes, sir.
Yes, sir.
There's foreign patients coming from overseas. They are not Indian patients. And this sort of surgeries, patient is alone, not accompanied. All cosmetic, half of the cosmetic patients, they come alone, and female. They say that we inquired. We used to get, where I used to work, many patients coming from Western countries and other countries and overseas and all. The rule says that you have to inform either embassy or consulate when you are operating this patient. Because suppose anything goes wrong, where are you going to whom to inform? Because they don't reveal about their relation anything. So the rule says that you have to inform the consulate that we are operating this patient who is a foreigner in India. So I just wanted to share this.
That applies to any surgery you do on a foreign national, and you have to, yes, and that is generally, we should check, but that is generally done by the surgical team already.
Specifically, these sort of surgeries, all cosmetic and these surgeries.
Okay.
Yeah.
Okay, sir.
Thank you, Renu. There are not many questions actually here. So we move on to our final case today. Dr. Kalpesh Shah is a senior consultant practicing with 2 groups, actually anesthesia groups that he has. One second, just let me change my
sharing. By sharing of
yes,
my
yes, sir. I don't have. Sir, आप अपना share करेंगे CV. Sir's case is about a reflex sympathetic overactivity after a routine brachioplexus block.
I think Renu has to stop sharing, and then I am able to do all. I am not allowed to share it.
Right.
Renu, stop sharing your screen.
हाँ, रेणु का screen on है अभी तक.
How do I do that? Because it's not happening. Yeah, I saw.
Yeah, stop sharing. Yeah. Yes, sir, please go ahead.
Yeah. Can you see my slides now?
Yes, sir.
Yes, sir.
Yeah. Okay. Good evening, everyone. Good evening to my teachers, colleagues, and friends.
My case is reflex sympathetic overactivity after brachial plexus block. I have to say something before I start this case. Number one, the best way to learn in our practice is a problem-based learning. And all problem, we get to understand that there are certain issues in our own management and we need to correct it. But there are certain sequence of events in a complication which sometimes changes your entire practice. This is one of the case which has changed my perspective of my entire practice, though it looks to be a very simple complication of a nerve injury, but it has changed in a lot of ways. I have presented this case in AORA, so I have gathered some references and some points to understand in our practice and apply in our practice. So within the continuation of this case presentation, I will narrate that also. So now just go to the case presentation. I mean my actual case scenario. 40-year-old ASA1, 80 kg male, who was a regular gymnasium workout addict, posted for lateral tendon repair. A very humeral condyle tendon was ruptured, and he had a continuous pain over there, and they were trying to repair it surgically. So as usual with the routine precautions and PAC and all, I'm not going in that detail. Brachial plexus block was given, PN is guided. Though there was a USG machine available in that hospital, but that machine was not available at that particular time, then I wanted to use that machine. And I was not really very keen on using USG for each and every case. So it's okay. I use the PNS guided supraclavicular, good and motor response, like flexion of the fingers in the first attempt without any much issues. Routine drug combination, ropivacaine 0.75% 20 ml, along with xylocaine 2% and NS 5 ml, with dexamethasone 2 milligram. Out of this solution, I have used 25 ml as a total volume. Block was adequate. Patient requested to be awake, and he was also quite chilled out guy. So no sedation was given. Surgery was in a supine position. There was no other issue. Uneventful. Tourniquet time was 45 minutes. So there was no excessive tourniquet time also. Now everything is fine. Patient shifted outside, and then the next day, I mean, in the late evening, I got a call that limb is still having a motor block. I said it's okay, it will go away. But exactly after 22 hours of my block, surgical team again reported that patient having a complete motor block in the operated limb. So obviously, then our first response is to attend the patient. And we all understand that there is some problem with our block. Sometimes it lasts long. I always tell my patient that it sometimes lasts for more than 24 hours. So it will go away in a couple of hours and it will be fine. Don't worry. So counsel reassured for the complete recovery, and patient has started regaining their some sensation, some part of recovery of the effect from the block within 25-30 hours, and after 36 hours full motor power is there, but there was some residual paresthesia on the tip of the index finger and the thumb. So again visited, again reassured, and again discussed with the surgical team and what can be the. I said it can happen that the block lasts a couple of time. It lasts for longer time, so it's okay. Advise low dose oral steroids, multivitamin to reassure. These are the medications also we try to give active to show that we are actively managing the patient. Even surgical team wants to show that they are actively managing and there is nothing wrong with the patient. So after a month, patient came back to OPD to the surgeons and they said that there is a congestion and heaviness in the operated limb if kept abducted and below the level of the chest, and symptoms resolved if it is abducted and above the chest level. So above the chest level, it is fine, but if it is lower the chest level, it is now I think you can very well appreciate the other hand is totally red. Operated hand is totally red and the other hand is normal. So, I mean, to understand this, we initially realized that there is some kind of sympathetic overactivity, and the patient is slightly anxious, so surgeon is more anxious. So now what to do? So involved a neurologist, and then he said that this is reflex sympathetic overactivity, CRPS, early stage. Now then we discuss and what are the CRPS. So CRPS 1 where there is no specific nerve damage, and CRPS 2 which is associated with nerve damage. Very early CRPS means starting of the sympathetic overactivity symptoms, and it may go to the extent of the highest form of the symptoms. Patient presentation varies from only a surgical symptoms or a, sorry, my presentation went up. Are you able to see my slides or not?
Yes, sir. We can see your slides.
But my
सर अगर आपका फ्रीज हुआ तो गो बैक एंड रीशेयर चलेगा.
I think so. Stop it here first. Yeah. Can you see now? Are you able to see?
Not yet. Not yet.
Now I can see. But you are not able to see.
We can see you.
Okay. Now? No.
नहीं सर स्लाइड्स नहीं दिख रहे अभी.
Slide.
आपका वेबकैम सिर्फ दिख रहा है, पीछे कृष्ण की फोटो दिख रही है.
कृष्ण ही मालिक है ऐसे सिचुएशन में.
लिटरली 1 महीने का गैप हो गया ऐसा लगता है.
हाँ हाँ.
पेशेंट 1 महीने के बाद आया तो हम भी थोड़ा टाइम रुकना पड़ता है भाई.
Now can you?
No.
अभी भी नहीं.
सर स्टॉप शेयर करके वापस से एक बार देखते हैं.
नहीं स्टॉप शेयर तो हो गया. नाउ इट इज अगेन आई एम शेयरिंग. नाउ अगेन शेयरिंग. ओके.
हाँ ये सभी शेयर हो रहा है. ये
कुछ तो हुआ, कुछ तो हो रहा है. आया क्या?
आया सर.
हाँ कुछ तो आया. चलो कुछ तो आया. हाँ so ऐसा ही. So now if we see what are the other forms of CRPS and their presentation. So there is always a sudden pain, and which is constant, which is long lasting also. Along with that, there is a skin temperature, skin color changes, swelling of the affected arm, change in the skin texture also, sweating, and growth of the nail and hair excessively, and impaired muscle strength, sometimes movement disorder. Actually, in chronic pain clinics, people come for CRPS treatment because of these things. Now, this patient does not have any pain, and these are only less than 10% of the patient are without pain in this typical early CRPS. My patient was in this category, and because of there was little less pain and there was no functional inability, patient was slightly less anxious and slightly less abusive to us. Now, CRPS is a sympathetically mediated condition. Now, sympathetic deregulation is partly responsible for all these changes. And a cold and blue limb could be caused by an upregulation or hypersensitivity adenoreceptor. This is the histopathology behind it. For treatment, psychological counseling, reassurance, low-dose oral steroid and multivitamin only works. And if there is a severe pain, then sympathetic nerve block is the treatment, like a stellate ganglion block is the treatment when the patient having a severe pain as well as having an inability to use that particular limb. Now, causes behind the CRPS, it can occur with the minimal trauma to the nerve at any level. In our case, repeated trauma to the elbow was due to the heavy exercise in the gym by that particular person. And I have given a brachial plexus block. And that injection would have created a nerve injury. Or, one more thing, surgical handling of the nerve during the entire process. Now, the main crux why it has changed my entire trajectory of my practice is because of the conflict between the decision of the where the nerve injury is. In such situation, we don't want to create any conflict in front of the patient, but at the same time, surgeon thinks that your nerve block has created problem, and you think that surgical handling or a patient own repeated trauma to the nerve would have done this thing. But then, how to prove? Honestly, I would say that we cannot prove or disprove anything. But whatever has happened, if we have a real scientific understanding, we can just put that scientific data in front of the patient and be ready for if this goes into the any medical legal scenario. So as we know, any problem, they look for the anesthetist as a cause. So they were not openly, but partially continuously blaming that there is a nerve damage during the nerve block. Now let us give me 2 minutes to explain you how the nerve injury thing works, which I have created from the references. So just have a basic terminology: epineurium, perineurium, fascicles, interfascicular space, endoneurium, Swanson's and malnutrition exon. These are the very important parts which we are largely understanding. What type of the nerve injuries happens during the nerve block? One is a neuropraxia, which is most common type of the nerve injury happening due to the various reasons where myelin sheath is damaged and conduction is slowing and blocking. Axonotomesis is a loss of axonal continuity. Endoneurium is intact, but there is no conduction into the nerve, which is really a moderate issue and it takes well of a time to recover. Neurotomesis is a loss of axonal and endoneurial continuity. Perineurium is in a trouble and no conduction happens. And last is complete nerve damage. There is no conduction at all, which always required surgical correction. Now, what are the mechanisms during our block? One is mechanical and injection injury. Second is vascular, that is ischemic injury. And third is a chemical injury, that is neurotoxicity. Intraneural injection, the most common, where I have to put my lot of articles in front of them, that is a needle-related nerve compression can result from forceful needle nerve contact from any approach, and the needle or injection inside the nerve itself. Needle or injection, both inside the nerve itself. It has been postulated that the intraneural injections may lead to the sustained high intraneural pressure when exceeding the capillary occlusion pressure around the nerve that produces the nerve ischemia, like in any major vessel doing the ischemia to the limb, and that will create a potential injury. Intravesicular injection. One of the main cause of block-related peripheral nerve injury is the injection of local anesthetic into the vesicles, causing direct needle and injection trauma, rupture, and the loss of protective environment within the vesicles. That will consequence to the myelin and axonal degeneration. Now, intravesicular needle placement and injection has to be avoided. Intravesicular needle placement and injection has to be avoided. Paresthesia and pain during the injection. Now, this is the one more thing which has changed my trajectory of my practice. 2001, when I was not very well versed about the nerve locators, I used to give blocks paresthesia by paresthesia technique. And after a couple of years of my practice, when I have given a paresthesia block to some young lady, supraclavicular nerve block, and that patient had a nerve damage. Now, after a couple of days of counseling by surgeon to the patient, finally surgeon gave my number to that patient and said that now you talk to this anesthetist. And that patient has harassed me for almost 3 months. Every alternate day talking to me about that I am having severe pain, I am not able to do this, and I have paresthesia, and I have inability to function. And that has provoked me to change my practice from paresthesia technique to peripheral nerve stimulation technique. This was in 2001 to 2004. And now this case has changed my practice from PNS guided to the dual mode technique from PNS and US. So paresthesia, neither the presence or absence of paresthesia during needle advancement or on injection of an anesthetic is entirely predictive of nerve injury. So this is also subjective. Elicitation of severe pain during needle advancement or an injection of local anesthetic should prompt cessation of injection, because that is a time where you are likely to damage the nerve. As we know, end motor response at 0.5 milliampere at 0.1 millisecond as an interval is a really good indicator. So keeping avoiding the injection at 0.2 is no doubt, but avoiding injection anywhere between 0.2 to 0.5 is also going to be in a danger zone. If it is a 0.5, then your needle is really very, very near to the nerve, or it can be intranuclear also. Injection pressure monitoring can detect the injection opening pressure as poorly compliant tissue, such as the nerve vesicles. Ultrasound can detect the intraneural injection, although detection may occur too late to prevent the injury, as little amount of drug is already gone inside and the rupture of the vesicle is already done. Current ultrasound technology does not have adequate resolution. So we all are facing this problem that all our USD machines are not that high end that we get all this information very easily in all the cases. Vascular injury, damage to the nerve vasculatures during the nerve can result in local or diffuse ischemia and can occur as a direct vascular injury, acute occlusion of the arteries around the vasonervum, and there is some kind of hemorrhage which we are not seeing, micro hemorrhages, and within the nerve sheath, and that can also give a vascular injury to the nerve. The epidural circulation in a critical component and overall neural circulation, and it is very important not to have it this. Now, for the sciatic nerve specifically, one observation and one large study has done about this is vascular supply of sciatic nerve is very less abundant. It has got a very particular particular specific nerve vascular supply. So, by putting an epinephrine, we get the longest prolonged block in the sciatic nerve because that vessel is getting vasoconstriction, and that's why we are getting the longest. This is another indirect evidence that our all vasoconstrictors put into the nerve blocks can potentially cause a vascular injury. Local anesthetic and adjuvant potentially reduce the blood flow in an agent and concentration dependent manner. So we have to be very, very careful about choosing the agent and the concentration also. Chemical injury, the site of local anesthetic application, that is extraneural, intraneural, interfascicular, or intrafascicular. This will depend, this will decide about the toxicity, and whatever the drug we are using, they are all are potential or able to do the neurotoxicity at particular concentration. So, and inflammatory injection, this is intrathecal or intraneural injection of ultrasound gel can also lead to the inflammation. This is where our sterility concept while we are doing USG guided blocks is very important because this has been reported. So, inflammatory injury is also one of them. USG guided blocks are not yet the answer because, as I said, I mean, we don't have that high resolution USG machines. So, I mean, probably applying peripheral nerve stimulator along with the USG is the probable answer to prevent such kind of injury. Clinically, intraneural injection into the extrafascicular connective tissue within the epineurium cannot be result into the nerve injury. Now, one more important point, needle bevel type. There are two types of the needle, which is long bevel and the short bevel. 45-degree bevel is much less likely to penetrate the perineurium and inflict the fascicular injury than the needle of 15-degree bevel. But however, once the 15-degree bevel went inside, that the short bevel needle does a more damage than the long bevel needle. Okay. We need to keep these points into the surgical side also, that surgical team can create a neuronal injury in form of traction, transaction, compression, contusion, ischemia, stretch. Maybe directly by tourniquet, directly by surgical technique, or by positioning method. But these are the factors which can lead to the neurological injury surgically. Presence of motor response less than 0.2 is absolutely specific and sensitive, so should be avoided. Less than 2, no injections. Peripheral nerve stimulation as a nerve localization technique is characterized by relatively low sensitivity but high specificity, and it has clearly proved over many years that it is one of the very important instrument to prevent the nerve injury. So it should be used along with the USG to prevent the intraneural injury. When a motor response elicited is low current and sensitivity, the needle tip is invariably positioned into the nerve. These are the certain statement of a big articles which has been given. These are the two new equipment which are into the market, that opening injection pressure monitoring. This is by Pajunk and this is by B. Brown. They are all working in a different manner, different principle. So inability to inject local anesthetic with opening pressure of below 15 psi, that will all 100% tell you that your needle is in somewhere else. So we'll have to be carefully rearrange everything and do the block in a different manner. Injection pressure monitoring may prove to be useful for its negative predictive value for functioning of the nerve, functional nerve injuries. as no cases of clinically significant neuropathy has been reported in literature with the low injection pressure. So if you are injecting with the low pressure, you are more likely to be safe. During nerve block injection into the perineural connective tissue should never require more than 15. So when you are actually injecting, it should not have more than 15 psi pressure. So, after all this journal reading of nerve injuries and all, I would always say that just nerves should be handled with care. I would really thank BSA for giving me the opportunity to speak on this. Thank you so much.
Thank you, sir, Professor. It was a difficult case in the sense, the convincing part, how to tell the patient, how to explain, and whether we are sure what is the course of the thing going to be. There are a few things that came to mind. Why did you actually think of it as a reflex sympathetic motor active instead of a simple thing like some vascular injury because of which there is congestion on the hand or something like that? A common thing that we expect in surgery.
So generally, what you said, vascular injury and common things comes immediate after the surgery. And this reflex sympathetic overactivity generally comes after a couple of days, weeks, or months. This is typically after a month, patient came back and started giving a complaint. And the more important is that there was no fit criteria sitting into the patient. There was no pain as such. CRPS, we expect the pain. As I said, only less than 10% patients have without pain CRPS.
Without pain.
So it was even confusing at that particular moment also. But then there were only couple of things which we can do. One is actually nerve conduction study. Now I tell you the practical point. By doing nerve conduction study, I would probably put me or my surgeon in a difficult situation by targeting that where is the problem, at the elbow or at the supraclavicular level. And I would always say that the team has to be very cordial when there is a complication. We don't want to expose ourselves in front of the patient that this is a problem and this could have been done. Okay, we want to be honest that there is some nerve injury. We want to be 100% honest. There is a CRPS. We are diagnosing it. We are diagnosing it with the help of the neurologist that, okay, you tell us what to do again. So neurologist said, this is CRPS. If you wait for a couple of days and patient may get worsen and may get pain also. But luckily it has not happened and patient become all right.
So is it a diagnosis of exclusion by the neurologist?
It is always a diagnosis. It's always a diagnosis of exclusion with the typical clinical picture of this sympathetic overactivity, flushing of the hand, color changes, or any sweating, or any pain, swelling. Because I have treated a couple of patients in a chronic pain management, so I know these symptoms are very, very, very obvious actually.
Okay. And in this case, the block had lasted for a long time. I mean, longer than expected.
Yeah.
Do you think it had any relation with this presentation later on? I mean, was there any reason which could have been responsible for both, for a prolonged action as well as some sympathetic whatever damage or whatever you're thinking of?
So I was being more dragged into the nerve injury part because my block acted for 36 hours. Say for example, this block has not acted for, it has got over in 6 hours or 8 hours. Then surgeon or in the surgical team or a patient or anybody, even me, myself also, I have no chance of thinking there is a nerve injury, right? So once it is 36 hours, why it is 36 hours? There are only couple of things. Okay, we added dexamethasone, but that also doesn't explain 36 hours. It can explain 10 hours, 12 hours, at the most
16 hours.
So this has 36 hours has started. Everybody was already in a mood कि block तो बहुत लंबा चला है. Means you have injured the nerve already, and now this patient came back with this. So there was a lot of silent blame on the anesthetist.
And in that photo, we only saw this discoloration of the palm.
Discoloration of the palm, yes.
But how? I mean, was there any level
limited
till which
to elbow?
It was
limited to elbow. Limited to elbow. Yes, it was not above elbow. So I
mean, is there any anatomic thing which can explain कि only elbow तक ही था? I mean, considering the sympathetic outflow जैसे आता है from T1.
Right.
Stellate ganglion. do we expect that to be limited to elbow or maybe
No, no, no.
some
It is
two fingers? Not like
no,
the blocks, like
not like the block.
not like the blocks.
So this question was asked to the neurologist also. So he said that okay, this is the beginning of CRPS. Now it can go into both directions. He will have a more morbid symptoms, or he may recover, and that we have explained very clearly to the patient. Okay, right now it is up to the elbow, but it may go to the above elbow also.
And another thing you mentioned was abduction used to relieve that thing. Abduction and
Exactly.
elevation or only abduction?
Hand elevation. So sympathetic overflow during the vasodilatation. Once you are putting your hand above the heart level, you are getting all this flow back to the heart. So now there is nothing. But in a normal situation, this doesn't happen. Say for example, right now, if you are putting your hand, it is not happening. But for that particular patient, it happens. Just the sympathetic system is not working.
There are no chat box questions actually, because like you explained so much in the end about the nerve injury and the types of injury. So I think anybody else has a comment?
One question is, what were the drugs that you used in this patient?
Ropivacaine 0.75 20 ml, 5 ml xylocaine 2%, 5 ml normal saline, and 2 ml dexamethasone. 2 milligram dexamethasone. 2 milligram. 2 milligram. We initially used to use 2 ml dexamethasone, but then after literature says that it doesn't make much difference. Even the minimum dose of 2 milligram works same. You use 8 milligram, you use 2 milligram, it works same.
So can I ask, sir, is IV Dexa with the block now the recommended thing instead of adding Dexa in the solution of the?
Yeah. So now we are not adding it. We are giving anyways. If we need, we use it, and we are not adding it. This was, I think, AORA during the COVID times, around COVID before. So a couple of years before, we used to use dexamethasone for all cases, but now we have stopped adding.
So IV Dexa you give?
IV dexamethasone we give. Yes.
It says the IV Dexa also prolongs the block equally.
Prolongs the block. And one more problem is that the dexamethasone, adding dexamethasone, does some precipitation of the drug in majority of the time. So it becomes that white solution. So I am always doubtful that my actual original drug will work or not. So it has been given us some, and we don't add dexamethasone now.
Also, sir, by using in blocks, prefer to use Xylocard, plain Xylocaine rather than
We are using Xylocard only. Yeah, we don't use plain Xylocard.
because that will interfere with vasa nervosum. Is what is
Absolutely.
Sir, was counseling very difficult for the patient?
Absolutely difficult. Counseling for myself was also difficult. For surgeon was also difficult. We were always every day we used to fight only on phone. Why this has happened? Why this has happened? If this patient sue any of us, what will be our answer? Because the patient was really high profile and he was very well connected. So if this had gone into the medical legal situation, I would have been in a big trouble. I would have to defend myself. That's why I say this is a landmark case for me that I have changed myself. The thinking process has changed. The use of sonography, the motivation to use sonography, the motivation to use better technique, motivation to use short bevel needle, motivation to go low dose, motivation to use PNS with USG, all this has been changed after this case.
So
Luckily,
was
it
it the
didn't go to the
non-dominant
medical
hand?
legal.
And was it the non-dominant hand?
It was not double.
Left hand it was.
It was left hand. And I honestly, it was no pain to that patient. Otherwise, it was a pain, then I would have a difficulty in giving a sympathetic block again. Going to the same nerves, giving block, and now going to sympathetic block with all this thing would have been a huge task.
You must have read a lot about this. Any factors which can predispose a person to this syndrome?
They say that family member, family history. Now, how to elicit family history? That's a big question. But family history is directly correlated. If somebody has a family history, it's directly correlated.
What kind of family history?
Family history, similar CRPS syndrome. Similar CRPS
similar.
syndrome. Now, similar CRPS syndrome in a history, if I want to ask, I would always ask that, is anybody is oversensitive to the pain? थोड़ा भी पेन हुआ बहुत दुखता है बहुत मतलब they are going beyond that control. So those patients are in a real difficult scenario for this. And one more thing we have learned about this is to clarify with the surgeon whether they really need a block or you can really avoid block in a previously injured nerves. Injured nerves means so-called injured nerves. So now this is a big debate again in all platforms, even in AORA, whether the injured nerve patient, you are repairing the nerves, you want to give block or not. So majority surgeons doesn't want to take that kind of risk. So we also should take part actively and discuss with the surgeons, see how they are approaching to this particular problem. Because if the surgeon is in a mode of a blame to the other party, then you better to stay away from that kind of block. Stay, give GA. All patients are fit for GA otherwise. So why we need a block?
Rao sir, any comments? Rao sir, yeah, बोले. Okay.
Anything retrospectively you feel you could have done differently to avoid this?
I would have been little more gentle with my PNS block. Little more gentle in the sense, sometimes we do all this thing on the spinal level. I mean, just went and painting, tapping, and just give a block, nice end motor response, and you just finish it off. But it requires little more patience and I think little more gentleness to handle the nerve. That's why I put that all nerve requires lot of care. Not that I have violated anything. The 0.5 milliampere I have given a block and all, but then I am literally little more softened to the nerve blocks after this incident.
But this
What
patient
is
recovered fully.
in literature, what is incidence seen of such nerve injuries or such kind of
ERPS. No, it is extremely rare. It is 0.001. And now the literature has a different, now different literature says different in the form of which kind of patient you are tackling. So in our type of the scenario, this is extremely rare scenario.
Yes.
And
Do you use
yeah,
this
please.
pressure measuring device which you showed us
No,
regularly?
I have just used it for my own experimental purpose only, just to understand how this devices work. But I am not using it because again, it is adding cost to the patient, and nobody is ready. Or a sterile needle is a big problem. That 1,300 rupees sterile needle is a big problem, and adding to the 800 rupees of this device is again a big problem. So it is
Even if
not
you use
practically.
it, take a video and post it.
Yeah, I will do that.
There is
Sir,
a
ये
question
clinic
in the chat box. Yeah,
Yes,
how the patient became normal and what treatment was given.
Yeah, so I mentioned the treatment was oral steroid, multivitamin, reassurance, and we were waiting for nerve regeneration, whatever has happened to reverse it. Yeah, but there was nothing more. Initially, we have given low-dose steroid orally, but that eventually we needed to stop it after 15 days. How many days you gave steroid? And patient had no pain, luckily, so we did not require many drugs. Otherwise, if there is a pain, we required all drugs of pregabalin, gabalin group of drugs on the higher doses, or we required all analgesics in combination, and then a sympathetic nerve block. So this was predominantly easy to manage kind of CRPS. I was lucky enough.
Sir, ये, when we give this block, have you ever realized that using this different syringes, like different sizes of syringes and different makes of syringes, can
Yeah.
also give that difference in feeling of pressure, how
Feeling of the
forcefully you are
pressure.
injecting,
Absolutely.
especially if you are injecting yourself. Somebody else is injecting, then you don't know how they're forcefully. But like just my clinical, ma'am, we were all giving
Yeah.
blind blocks for so many years. As soon as you connect an extension tube, the pressure increases because you have to inject through a longer tube,
To a
through a
longer
longer
route.
PNS needle. And
Yeah.
when we are using that 1.5 inch needles for blind blocks initially, simple needles. That time also we realized that if you use a smaller syringe, you actually inject more forcefully.
More forcefully, yes. Smaller in syringes, you use
They
more force.
create more pressure because they are softer to handle. In if you are handling if you are using a 20 cc syringe, you might feel that I बहुत force there, but actually the pressure is not so
Not
much at the tip.
transmitted over there.
Yeah.
So what I mean to be, I become little softer in the sense I am injecting the drugs very slowly now.
Okay.
But otherwise, in private practice, all of us know that we all are perpetually in a hurry to do everything. So you give a block fatafat and then you give an inject it fast and everything is fast. But then with the nerve blocks, I become slightly better with that injection technique because we don't have yet we are not using pressure monitoring system. But yeah, I think it will come soon into the practice. The days are there that we are heading towards that.
Thank you very much, sir. It was a very delightful discussion, actually.
Yeah.
A lot of things to learn. Today, actually, all the speakers were very good. All the cases were good. And this
Absolutely.
was the, I think, the most discussed case probably. Because
You
everybody
are
is
very
scared of
good.
complications.
You are very good in asking questions. I must say
No,
that.
but see,
You
everybody
ask
is.
my all questions which are in my mind. So
See,
extremely
we
good,
are
and
all
thank you so
scared
much.
of patients, all scared of
Absolutely.
complications in a otherwise seemingly normal case. So one 45-minute surgery, if patient lands up in problem, it's difficult to convince
Explain.
and
Yeah,
convince
yeah.
yourself first.
Absolutely.
For a very that GI bleeding when the patient's HB is very low, patient is risky, adrenaline is high, but we can manage. But this was yes, sir. Abdul sir, any comment, sir?
No, excellent. I mean, lot of learning from each case.
Yes.
One more comment. I was listening very comfortably that perimortem cesarean section. We had one case of perimortem cesarean section. So I would say that obviously all obstetricians, my wife is obstetrician, they are not very convinced for doing LSCS in that situation. That is a norm, but it is our duty to make them understand and our duty to educate them and then tell them with the references. And then so we and my wife has discussed this before, and one fine day we land up in that situation. We literally did perimortem LSCS. Patient revived because the baby was out. So in a Prajakta's case, probably she was lucky that without removing the baby and mother both
They
are
could
fine.
revive, yes.
She could revive. Then there was a very
Still the
lucky
baby
situation.
survived.
But then
Did not suffer hypoxia. Yeah.
I would say that I take a lead.
I have a
Obstetricians are worried.
Yes,
Obstetricians are worried that if still they have not touched the knife, they feel that
Absolutely.
they are not responsible.
They are not responsible.
Once they touch the knife, everything the blame can come on doing a surgery and having a problem.
Sir, but it is like, some patient has collapsed and you say कि मैं अगर CPR देने गया तो मेरे को गाली पड़ेगी. See, we know that if you give CPR, the patient may survive. And we believe that. That's why we give CPR. People who don't believe that CPR will save lives will always have this doubt whether we should start because we have not touched the patient. Once you touch, somebody will say कि तुमने आके chest तोड़ दिया उसका. Or you broke the rib or something happened. So it is because Foxy does not discuss perimortem CS, so they don't know that perimortem
we need
CS
to
is
educate or
to
discuss
save
with the
the mother.
Mortality
It has nothing to do with the baby. It is to save the mother.
Mother, it is to
That
save the
they
mother.
have to, somebody from our maybe association, जैसे कल्पेश सर जाते हैं कभी-कभी inter faculty meet में, somebody has to convince them that it is not for that baby. Caesar is always for baby for them.
I think we can take Prajakta's case in the interfaculty. We can have one and take Prajakta's case and general discussion.
We should discuss that.
Next कभी भी रहेगा, sir, we'll take that up. We should take that case.
Yeah.
Let them know, just like we talk about CPR. Yes, please.
I just have a word to put in here, if I may, for just a minute. As you said, CPR में हम डरते हैं ना कि chest टूट जाए कुछ करेंगे. But see, there you already have a collapsed patient. The problem with obstetrics is it's a very physiological condition. So explaining morbidity in a physiological condition becomes very difficult. Forget mortality. So ये थोड़ा difference between
Actually, by the time we think of
but it was
perimortem, the
actually a
patient,
very
it is
ideal
not a
setup for perimortem
it is not a
LSCS.
physiological patient.
Yeah, it was a very ideal setup for a
Setup for a
perimortem.
perimortem LSCS
Absolutely.
because patient
Yeah.
was in OT, there was anesthetics available, there was obs available, so it was and
Yeah.
staff was already there, the trolley
Already
was
there.
already made,
Yes.
everything was already available, so it was an ideal scenario for a perimortem LSCS.
Sir, this because of this anaphylaxis thing, I wanted to ask, हम लोग antibiotics देते हैं patients को. In that last medical legal webinar that we had, somebody said, I don't give. So one senior person, medical legal expert said, I don't give. I tell them, ये तुम्हारा काम है. But then, how does it help us? Because most of the times, many of our colleagues, they ask us to give the antibiotic so that we are present there. कुछ होता है, at least you can manage. Because they are sure that if it happens in our absence, their staff may not be able to manage.
I have seen the cases with test dose also. They have just collapsed. What to do?
Madam, I had one patient, laparoscopic hysterectomy done, Antibiotic was not given. So in the end, when everything was done, they said, "अरे वो antibiotic रह गया, dissolve करके रखा है." So we put that in 100 ml NS while the sutures being taken. सब last का हो गया, and the drip got over. Normal RL वगैरह लगाया, pulse BP देखा, patient awake, बातें किया, GA था, extubate हो गया था patient से, बात किया, patient नाम बताया, सब किया, shifted the patient on trolley, and there was another some MTP or something. So I stayed in the OT. The RMO and the staff and Maushi, they shifted the patient to the side room, or just बाजू में room था. And in 5 minutes, maybe 3 minutes, that Maushi came running. Sir is calling. The consultant was there with the patient. Sir is calling you. जाके देखा तो patient was frothing at the angle and disoriented kind of. Then first we thought चलो suction करते हैं, शायद vomit किया है. And then I saw the pulse, very feeble pulse. Then I thought of reaction. Adrenaline दिया सीधा उसको. And they didn't have a NORAD. So वो adrenaline का ही थोड़ा सा बचाव ड्रिप में डाला, उससे उसका बीपी आया, पेशेंट को इंट्यूबेट किया, थोड़ा देर वेंटिलेट किया, पेशेंट स्टार्टेड ब्रीदिंग वेल, आईसीयू पे फोन किया, आईसीयू एम्बुलेंस मंगाया, पेशेंट शिफ्ट किया, पेशेंट वाज पुट ऑन वेंटी फॉर अ डे, required an NORAD support till next day morning, and then it was tapered off, extubated next day. Then they said कि अरे उसको उधर ही रखते हैं अपन, and we'll discharge the patient from that hospital only, not from our nursing home. So for 5 days the patient was traveling. Every day they would ask, किसका गलती था, किसका गलती था. ना गलती तो मेरा ही हुआ ना सर, because I was the one who gave injection. Before that patient was okay. Patient was extubated, talking, and shifted, and the gynecologist did not actually come to defend कि नहीं, it is because of that drug that you, and because he was there you survived. If he had left after the case, he would have also left.
He would have.
But then हमारे ही colleague they also felt कि अरे मतलब they never felt कि मैं था इसलिए survive हो गया patient, कि उसको intubate हो गया. They could not have intubated, obviously nobody was there. तो ये एक issue है ना, face करते हैं हम लोग, we don't know medically के लिए उनको मना करते हैं क्या सर कि antibiotic will not give.
Hello.
So it is not only about antibiotic. I remember my senior telling me that you take every drug as a potential, thing. Even paracetamol, I've seen reaction to paracetamol, though small reaction, not a full-fledged anaphylaxis. But no drug is safe. Every drug you have to take with a pinch of salt and be careful in administrating it, and should be able to manage if something goes wrong.
But if this had happened after I had left, I mean, patient तो shift हो ही गया था. I got a call because I was still in the OT. That's what I'm thinking. How it would have come to me? I mean, how would have I explained myself? Save कैसे करता मैं अगर कुछ हो जाता patient को?
अगले दिन पेपर में आ जाता drug overdose.
That's what I'm thinking.
I think Dr. Naresh Paliwal sir wanted to speak something.
Hello.
Yes, sir.
Yeah. Good evening, everyone. Just wanted to share a case about perimortem, not exactly perimortem LSCS, but a patient very early in my practice, actually somewhere around 88, 89, when my senior anesthetist was in a habit of giving atropine to every patient. And he gave atropine to one LSCS patient, and that patient went in LVF. And that time there were no phones and no boils machine, nothing was available. So the surgeon came rushing to my place, which is around 3-4 kilometers away from his hospital. Then the midway I told him, just because of atropine might be the patient is in LVF, there was cyanosis. And by the time I reached there, the patient was having froth coming out of the mouth. Asked the surgeon whether the FHS are there or not. He said, yes, they are there. So I just gave Lasix-Digoxin, which was only available drugs that time. No boils was available, just supported with oxygen, and gave a low dose spinal to have reduced the afterload, and that worked. I could save both baby and mother also. So that was a very, limited resource setting in the government hospital. So the patient could be saved. After some time, she got relieved of that pulmonary edema. Actually, when I reached there, the froth was coming out of the mouth. She was cyanosed and extreme tachycardia. Pulse was not palpable. But still, I used low-dose spinal to, in the thinking that it will reduce the afterload. And also, the LSCS was done by the time. The baby, though fetal distress was there, could be saved. So, delivering the baby can reduce most of the things if you do early LSCS in such cases.
I think we don't have many questions here. So it was a nice discussion today. Lot of learning points. Almost every case gave us a take-home point. I would request Dr. Yogendra to do the rest.
Just
Yes. Just on a lighter note, I would like to salute, double salute to Kalpesh, convincing his wife and gynecologist. Very good.
only for
Gynac को
the
convince करना possible है मैडम, wife को convince करना ज़्यादा difficult है.
हाँ, मतलब it is only on the academic part only, yeah, till then.
It is like wife raised to gynac, ऐसा है. हाँ sir.
Yeah, just before we conclude, एक अपना the last response to our last two webinars, today's and last time physical, fantastic response, shows that people are interested in coming out with cases and discussing it. And as decided in our AGBM, it is going to be the basis for our Dr. Kamdar sir BSA prize, which will be awarded to the best case presentation for our branch and one from the state level for private practitioners. So from this year, September 14, the first BSA con we are having, we will be announcing the first Kamdar sir BSA prize for the best cases. Details will come up soon. Yeah.
Yes, sir. I've already started receiving emails for that. For the cases, people are interested.
Excellent.
Yes. So our next physical meet, the major BSA Con 1, will be on 14th of September, Sunday, at Sai Palace, Malad. We are going to have big faculties, national level office bearers, and so I request everyone, as soon as the flyer is ready, with registration will come out in next few days. That's it for today. Yogendra, please take over.
It was a wonderfully organized CME. Thanks to all the SAMS office bearers, Anita ma'am, Rajesh Tagadpalli sir and team. Thanks to all the ISA office bearers, Amola ma'am, Rajiv Garud sir, Rajesh Rao sir, Tejveer sir, Shilpa ma'am, Kalpesh, Neeraj sir, and Ganesh Tendulkar sir. Thanks to Ganeka for their technical support. And thanks to all the speakers, starting from Prajakta ma'am, Shagufta, Rahul, Avdut sir, Renu, and Kalpesh sir. And this was a wonderful CME, which was attended almost most of the times. It was more than 100%. It was 100% attendance was there. And thanks to the moderators, Tejveer sir and Dr. Ashwini. And thanks to all the people who have shared their experiences and made us more wiser what to do and what not to do in this situation. And with this we end this case. That's it. Thank you.
Yeah,
Good
good
night,
job,
everyone.
Tej.
Thank you, ma'am.
Tejveer has done a very good job today. Very
Thank you, ma'am.
nice.
Very good.
And I think, ma'am, we should have more of these cases, scenarios, and all that.
Yes, yes. I think we learn a lot from them.
Yeah, and that gets the best out of so many people. Like this Shagufta was a wonderful speaker today.
Shagufta was very good. Everybody was very
Rahul was very good. Means they have, I've heard them for the
was,
first time. Renu was wonderful. Avdut sir, Kalpesh sir,
all
they
of
are
them.
always wonderful.
Always good.
It was
Always
a
good.
very nice, organized CME, and all.
Yeah,
It was
we
wonderful.
get to learn from other people. That's very nice.
Yes, ma'am.
Thank you
We'll
very much.
continue with Yes.
Yeah, this will continue. And Shilpa ma'am has to do a lot of work now.
Shilpa madam was the person for this. She is the one who brought out bulletin after forcing people to share their cases, and people are not willing. She even forced me, actually. And then later on, it turned out to be very good discussions, basically because of that. So thank you, Shilpa. And she also gave me a few ideas about today's webinar, definitely. So thanks again, and we'll just
wind up for the day. Yeah.
Wind up for the day. Good night, everyone. See you in the next physical CME.
Good night.
Thank you. Thank you, ma'am.